Good morning, one and all. On behalf of Vishnu Dental College, myself, Dr. Vamshi Priya, third year postgraduate student from the Department of Prosthodontics, Vishnu Dental College, extend you all a warm welcome this beautiful monsoon morning. The CDE program entitled Pragmatic Occlusion Balance, organized by Vishnu Dental College, Bhimavaram, in association with Indian Prosthodontic Society, Andhra Pradesh and Telangana branches. Just like nature, balance is not something you find, it's something you create. With this note, we shall explore the learning journey towards occlusal balance. To begin, let us seek the blessings of Almighty with an invocation song. Proceed with the kind words of Dr. Suresh Sajjan Sir, President-elect IPS AP Chapter and Head of the Department of Prosthodontics at Vishnu Dental College. Passion is the most important trait of an educator, and Dr. Sajjan Sir is the real meaning of passionate teacher. And we are very fortunate to have such a dedicated academician who always guides us to overcome all the hurdles at understanding prosthodontics. Sir, I request you to welcome the audience.
Thank you, Dr. Vamshi. Namaskaram to all. Very good morning. Respected Chairman Sir, Chairman of our Vishnu Educational Society, Vishnu Raju Sir, and respected President, IPS President Dr. Rangarajan, and Secretary Hari, and our state IPS President and Secretaries also here, Dr. Narendra and Dr. Shesha Reddy. And I also acknowledge the presence of Dr. Nair Sir and Manish. I cordially welcome all of you for this on this occasion of continuing dental education from our Vishnu Dental College regarding balance articulation. I always used to think that having the teeth arranged in balance would reduce a lot of complications for the complete dentures after we achieve so much with all the different steps. And if we miss out this step, it would cause problem to the patient. That's how I used to look at it. And I always used to feel that this is one area that we still need to give sufficient emphasis while arranging the teeth. So in this context, we planned for this program where we can train the students, especially the first year postgraduates, where they have started beginning their preclinical prosthodontics and so on. I thought this is a good foundation that we should lay down for them to proceed with. And on this occasion, our institution has progressed so much, and with all the vision of our chairman sir and our director sir and all the faculty from Vishnu Dental College as working together as a team, a family. And I welcome Vishnu Raju sir and the director sir on this occasion. Our Indian Prosthodontic Society has been supporting for all the events that are happening in India, and specifically in Andhra Pradesh, we have a very good leadership team here. And I also see that in the past, of recent, there are a lot of programs happening throughout India, and it is all because of the efforts of the head office, headed by Dr. Rangarajan and Dr. Hari. They are very known and very efficient, and they have made this kind of programs very well, and it has been made to be aware for the whole nation, making the whole country proud, and also contributing a lot to the knowledge of prosthodontics, our profession. So I welcome both of you on this occasion. We also have Nair sir and Manish. Dr. Rupinder is also there. Although I am not able to see on screen, but they have been contributing for our program for the didactic part of it. I welcome you all, sir. And Dr. Mahendranath Reddy was supposed to be also today with us here, but due to unforeseen events, he had to stay back, and he would not joining, but he has conveyed his best wishes to us. Well, on this day, we will be having a hands-on program also for the 21 students. And I wish they will all have a good exposure. And if necessary, we don't mind to conduct a few more programs like this, where ultimately we have to share whatever the knowledge that we have accumulated with us over the years. That is how I look at it. So once again, on behalf of all the organizing committee here and the Vishnu Dental College and the IPS Prosthodontics, IPS AP and Telangana branch, I welcome you all for this continuing dental education. Thank you. Good day. Jai Hind.
Thank you, sir. Thank you for your kind words. Now I request our dynamic chairman of Sri Vishnu Educational Society, Sri KV Vishnu Raju Garu, who always strives to fulfill the dreams of founder chairman late Padma Bhushan Dr. BV Raju Garu by following his path to promote the cause of education and serve the society. Sir, I request you to address our participants.
I'm very happy to know that Vishnu Dental College, with the support and collaboration with the Indian Prosthodontic Society, Andhra Pradesh and Telangana chapters, is conducting a 2-day workshop on the Pragmatic Balanced Occlusion on September 23rd and 24th. I am very happy that some very eminent faculty are conducting this program. Dr. Suresh Sajjan, Dr. Mahendranath Reddy, Dr. Chandrasekharan Nair, Dr. Bhimavaram Rao, and Dr. Manish Katyayan. Thank you all for taking time out and conducting this wonderful program. I'm sure all the participants will be very happy and there will be a good number of takeaways. Once again, congratulating the Department of Prosthodontics and Vishnu Dental College. I wish the 2-day event all success. Thank you.
Thank you, sir. It's my honor to introduce Dr. Rangarajan Sir, President of Indian Prosthodontic Society. Sir has graduated in dentistry from the Faculty of Dentistry, Annamalai University, Chidambaram in 1988, receiving the Best Outgoing Student with Gold Medal, and he completed his master's degree in the specialty of prosthodontics from R. Ahmad Dental College, Kolkata in 1993. He is the first South Indian dentist to receive the diplomate in oral implantology from the International Congress of Oral Implantologists, New York, for his work in his field. He is one of the first Indian dentists to complete the fellowship course in temporomandibular disorders, orofacial pain, and dental sleep medicine conducted by Smile USA and Roseman University in 2018. He has delivered more than 100 keynote lectures and conducted more than 100 hands-on workshops in national and international conferences. He has appeared on popular local television programs like Mangaya Chais, creating awareness on various aspects of oral health and dental treatments. He is currently working as professor and head Department of Prosthodontics at Sri Venkateshwara Dental College and also works in editorial board Quintessence India. He is a council member for Asian Academy of Prosthodontics. Sir, I request you to speak a few words. Sir is not available online. So I request Jangal Hari Sir, Secretary, Indian Prosthodontic Society, to speak a few words. He has done his undergraduation from AMES Dental College and Hospital, Raichur, and acquired post-graduation from Meenakshi Ammal Dental College. He started Advanced Dental Academy Exclusive Implant Training Center at Hyderabad in the year 2010. He had trained more than 340 participants in the field of implantology. He has received fellow and diplomat from International Congress of Oral Implantology in the year 2012. He has received master class certificate in biometric digital occlusal analysis from Milwaukee University in the year 2014. He has received fellow and digital smile design from Digital Dental International in the year 2015. He is presently working as Joint Secretary for Indian Prosthodontic Society and Secretary of Digital Dental International, Vice President, Indian Dental Association, Deccan Branch. He is also working as Director of Advanced Dental Academy, CEO H Dental of World Class Dental Care. Sir, I request you to speak a few words.
Good morning.
Yeah.
Very good morning.
Good morning.
Chief Patrons, Dr. Vishnu Raju Sir. Respected Ananda Raju Sir, Vishnu Dental Society Director. And my guru, my mentor, my life changer, Dr. Nair Sir. Sir, thank you. And IPS AP State Branch President, Dr. Narendra Sir. Secretary, Dr. Shesha Reddy, and all the office bearers of IPS AP State Branch. President-elect, Dean, and backbone of this program, and inspirational teacher, Dr. Suresh Sajjan Sir. And all the Department of Faculty, Department of Prosthodontics, Vishnu Dental College, and Secretary of this program, Organizing Secretary, Dr. Bhimavaram Rao, and Scientific Committee Chairman, Dr. M.S.N. Raju. All my dear students who is attending, welcome you all to this 2 days most intense learning program, and which is really useful. On behalf of Indian Prosthodontic Society Head Office, first of all, I thank and I congratulate Vishnu Dental College for ranking 24th for all over the country, and same thing 18th rank, which is published by Week and Outlook. And it's great to see the first institute who is having RFID instrument tagging. Apart from that, it's not only the numbers which shows that everybody knows in the entire Andhra Pradesh is one of the best institutions who delivers the best scientific content, and now expanding to teach clinically with a lot of scientific satellite clinics entire Andhra Pradesh. On the head office side, we really congratulate the management and entire staff of Vishnu Dental College management who is taking care of the faculty and also promoting this kind of scientific events. I thank you one and all who is attending for this program. On behalf of head office, I really thank AP State Branch for bringing such a brilliant programs. I have seen last year, I have attended Face the Final, again this year, Pragmatic Occlusal Balance. A really inspirational programs and really learning curve for the lot of students. And again, I thank and a good news for AP State Branch with this most active participations continuously. We have allotted a national conference for 52nd IPS National Conference under the leadership of the AP State Branch members, which is going to held in Vijayawada. My best wishes to everyone, and I thank all the faculty who is sparing their time and knowledge to share to the students. And before ending, I thank my teacher again, Nair Sir, Naidu Sir, and Mahendranath Reddy Sir. I am here this position because of they called me to this stage to bring. Actually, when I saw the inauguration yesterday, then only the stress started again, talking in front of Naidu sir, remembering again the seminar, the morning first lecture, which, sir, the things which you taught us is till the last moment of life is never forgettable. Thank you, sir. Thank you for everything. Looking forward to listen. It is great. The students have great opportunities still learning from you. Thank you, sir. And my best wishes to the program. Jai Hind, Jai IPS.
Thank you, sir. Here with us, we have our beloved Dr. Narendra sir, currently serving as President in IPS AP chapter. Sir has graduated BDS and MDS in Government Dental College in 1988 and 1997 respectively. Sir, kindly speak a few words.
Good morning, one and all. I would like to congratulate Department of Prosthodontics to Dental College for arranging a nice program on balanced occlusion. It is an important topic for postgraduate students. I hope the students will utilize this opportunity and improve their skills. Thank you. Thank you very much.
Thank you, sir. I would like to introduce Dr. Shesha Reddy Sir, IPS Joint Secretary. Sir has completed BDS and BDS from Sharavati Dental College, Shimoga, and MDS from Sri Balaji Dental College. He is a part of organizing committee in 2014 PG Convention, Vishakhapatnam, and in 2015 IPS Conference, Hyderabad. He is Secretary of IPS AP chapter. He presented papers at national and international level. I request Dr. P Shesha Reddy Sir to speak a few words.
Good morning to the respected seniors, sir, Dr. Suresh Sajjan sir, Dr. Chandrasekhar Nair sir, and Head Office Bearer Dr. Jangal Hari sir, and a warm welcome to all the dear colleagues and the postgraduate students who have traveled from all over the India to attend this one, and online viewers also. First, I'll thank the management of Vishnu Dental College and the staff who has taken initiation in doing such workshops. Earlier, they were doing the same thing, they are following the one. Earlier years, they used to do the finals for the exam going postgraduate students. And this year, with inspiration of Dr. Suresh Sajjan sir and Dr. Bhimavaram Rao, they want to do a unique one, that is balanced occlusion. Our balanced life is important for a human being. The same way, I think balanced occlusion also is important for a prosthodontist in exam point of view also. And I welcome them and I wish them to continue the same thing in conducting, sharing their knowledge with all the thing. And I once again thank the head office, Indian Prosthodontic Society, in extending their support, their motivation in conducting such programs in future also. Thank you. Thank you one and all.
I would like to take this opportunity to introduce two dynamic ladies in prosthodontics, Dr. Manju Madam and Dr. Vidyashree Nandini Madam, moderators of our first session. Dr. Manju V has completed her BDS and MDS from Government Dental College, Trivandrum, and PhD from Amrita Vishwa Vidyapeetham. She is currently working as professor and head of the Department of Prosthodontics at School of Dentistry, Kochi. And also she is a consultant at maxillofacial prosthodontist in the Department of Head and Neck Surgery in Amrita Institute of Medical Sciences. She has also worked as visiting professor in maxillofacial prosthetic division at University of California, Los Angeles in 2018. She has achieved International Creative Circle Award for New Innovations in Maxillofacial Rehabilitation Conference held at Bangkok in September 2008. Dr. Vidyashree Nandini Madam has graduated from Bangalore University and post-graduated from Rajiv Gandhi University of Health Sciences. And she is currently working as professor and head of the department at SRM University. She is the first in India to complete DNB in prosthodontia. It's our immense pleasure to have you both here, madam.
Yeah, have they unmuted? Yeah.
Madam, you can start.
Am I audible?
Yes, ma'am.
Thank you for your kind introduction. So, respected chairman, principal sir, faculty members, and IPS head office, Jangala Hari sir, Dr. Manish, and the entire team. Thanks to the Vishnu Dental College team for inviting me for this session, for moderating Dr. Chandrasekhar Nair sir's session. Actually, I consider it as a great privilege to introduce our Prostho Guru, Dr. Chandrasekhar Nair sir. As you know, sir is an exemplary academician who molds the character, caliber, and future of many dentists across India, including me. So, about Chandrasekhar Nair sir, it's a long list. Actually, sir has completed BDS in 1971 and MDS in 1983 from Government Dental College, Trivandrum. Till 1997, sir served as a faculty at GDC, Trivandrum. Presently, he is working as Professor Emeritus, Sri Shankara Dental College, Varkala. Sir has received Good Service Entry Award from Government of Kerala twice. He is the recipient of Neo Literature Award from Government of India twice, BC Shaw and TM Udani Orations Award of Indian Prosthodontic Society, Dentacharya Award instituted by the Kerala Dental Council. About Sir's publication, Sir has authored 19 books, including a primer on complete dentures, edited Phillips Science of Dental Materials, Asian edition, first and second. Then Sir has more than 250 articles in professional journals. Sir served as the chairman, Board of Studies, Kerala University, and member of Faculty of Dentistry, Kerala and Calicut Universities. Sir has designed and developed 12 instruments used in prosthodontics, including a semi-adjustable articulator. Sir's special area of interest, of course, we all know, maxillofacial prosthodontics, then dental education. So it goes on like that. So we are eagerly waiting for your session, sir. So over you to Dr. Chandrasekhar Nair, sir.
Thank you, Manju, for the nice introduction. See, my lecture is already recorded. They will play it for all. And I have to thank Professor Suresh Sajjan and his team and IPS for giving me this opportunity. Good morning to you all. In the pre-implant era of prosthodontics, balanced articulation was a 5-star subject. And it was not easily achieved while fabricating a complete denture. But in postgraduate courses, this has become a compulsory exam subject. I have been asked to give an introductory lecture on balanced articulation. Now I shall share my screen. May God bless you all. See, the title of my presentation is An Introduction to Denture Occlusion. Occlusion means what? It is the static relationship between the incising or masticating surfaces of the maxillary and mandibular teeth or tooth analogs, whether it is natural tooth or artificial tooth. The term occlusion stands good. Then what is CD occlusion? Occlusion which provide maximum denture stability and masticatory efficiency without compromising the health of the underlying tissues. Occlusal contact means the touching of opposing teeth on elevation of the mandible. A new dimension is added to denture occlusion, that is, giving stability to the denture, and that is the primary or secondary function of denture occlusion. Now, balanced articulation. What is that? Bilateral simultaneous occlusal contact of the anterior and posterior teeth in excursive movements. That is actually balanced articulation. Then which is the balancing side? It is the name given to non-working side in dentures. In centric, both sides, working and balancing sides, will have contact. In lateral excursion also there will be contact. This side is the working side and this is the balancing side. And natural dentition versus denture. There are some differences. Effect of occlusal disturbances are transient in natural dentition, but in dentures it causes immediate destabilization because the force will be affecting individual tooth and they act as individual unit also. 32 natural teeth means 32 individual units and it can withstand the force efficiently. Effect of non-vertical force affects only involved tooth of the natural dentition and to a great extent tolerated, but denture gets destabilized and can cause mucosal injury. That is the difference when a denture is facing non-vertical forces. Act of incision will not affect posterior teeth in natural dentition, whereas dentures can get destabilized unless it is balanced. So here you can see in the act of incision, anteriors come into contact, but posteriorly on both sides there is a disocclusion. But this situation we cannot copy in the dentures, then it will be destabilized. And this is a balanced contact. Anteriors as well as posteriors are in contact during protrusive action. And no balanced contact is required in natural dentition. And it is termed as interference if it happens with natural dentition. Dentures require balanced contact to ensure stability. Complete dentures, which are made to fit onto the mucosa-covered residual ridge, remain static only when the jaws remain static. When the jaws move, dentures will also move. When denture teeth contact in a pattern similar to the natural tooth, it is quite obvious that unwanted movements will be induced in the denture bases and tipping of the dentures is caused. An occlusion that balances both sides and anteriors with posteriors is a logical solution to prevent destabilization and subsequent pain and injury. Whenever we listen to the term balancing, this yoga posture comes to our mind. Or this posture of the elephant in a circus This also comes to our mind. And it is not an easy job. It requires continuous practice. And for us, we may see that it is very easily done. But years of experience are required. And for wearing a mandibular denture, if it has to function against the maxillary denture, in the hostile atmosphere of muscular forces, it requires some training for the patient. But years of training may not be there. One is the neuromuscular control, the God's grace, will make it stable. Second one is the balanced occlusion we provide. That also helps to keep the dentures in a stable position. But it is not easily achieved. Why should there be balanced articulation? It improves the stability of the denture. In the previous slide also I said it improves stability, reduces cuspal interference during mastication. See, the natural cuspal form can interfere. The upper and lower will interfere each other, and that can cause destabilization, especially the mandibular denture. And it preserves the residual ridges by better distribution of forces. Because most of the time, the balanced occlusion will provide fair distribution of masticatory load onto the residual ridge. And what are the goals of the balanced articulation? One is simultaneous contact in centric relation. Both sides, usually we get posterior simultaneous contact in centric relation. Balancing contact in protrusion. When the patient is protruding, anteriors as well as posterior teeth of both sides will be in simultaneous contact. That is protrusive balance. Working side contact and balancing side contact in lateral escutcheon. When the mandible moves to one side, the side towards which it moves is called working side, and the contralateral side is the balancing side. On both sides, there should be simultaneous tooth contact. See, here I am trying to show you the difference between natural dentition and a complete denture. And this is the centric position. And in protrusion, you can see the posterior teeth are disoccluded. And on protrusion, in denture, the anterior and posterior teeth are in contact. Here the incisors are in contact, and all posteriors are also in contact. And this is lateral escutcheon. The mandible is moving to the right side. These two pictures are natural dentition. Canine makes a contact and disocclusion happens. See, in dentures, disocclusion cannot happen. This is the working side, and there must be contact on this side as well as on the contralateral side in dentures. See, when the mandible moves to the left, see here in this picture it is evident that both sides posteriors are disoccluded. And this is when the mandible moves to the left. If it is a complete denture, balancing contact will be present. So the differences between natural dentition and dentures are almost evident in these pictures. Now, certain factors on which CD occlusion was evolved. See, the present day complete denture is the result of hardened observation and sincere research that has happened in the past. The first subject of research was posterior tooth form. People identified that the tooth form is the destabilizing factor. Then people have started evolving occlusal schemes, and Hanno has given a listing for the factors related to balanced articulation. Posterior tooth form, which we presently use, are three in nature. One is anatomic. These teeth are anatomically designed, just like anatomic tooth. It will have cuspal height. And then people identified that this height of the cusp will be interfering and destabilizing. So initially people thought of reducing the cuspal angle to 20 degrees, and it has in fact made the operator's job easy to make balanced articulation. But in extreme cases, we will be forced to use non-anatomic teeth. It is almost 0 degree, because in ACP class 3 and 4, we may have to use non-anatomic, and non-anatomic mandibular teeth are used along with the lingualized occlusion also. Now the occlusal schemes. Non-balanced, that is also an occlusal scheme, because in the initial stages people followed natural dentition blindly. Then they understood that non-balanced occlusion can destabilize. See, when the anteriors are in incisive contact, the posterior portion of the dentures will get destabilized. Then balanced occlusion, bilateral balanced occlusion was the next evolution, without much modification to the cuspal height. Even though with great difficulty we could get balanced articulation, it was not an easy job. Then third one, lingualized and balanced. And here the force distribution started through the lingual cusp or palatal cusp of the maxillary teeth on a heavily modified mandibular posterior tooth. And occasionally 0 degree posteriors are also used in the mandible. And this is the lingualized occlusion scheme. And the lingualized occlusion scheme is popular, especially when the residual ridge is not adequately formed, the height is compromised. The next factor is Hanno's squint. Rudolf Hanno lived between 1881 to 1930. He died at a very young age. The name of Hanno is synonymous with the articulators. He was engineer by profession, born in South Africa, educated in Germany, and worked in US. And he has listed certain factors. Initially it was some 13, and then he only realized these many factors are not necessary. So the quint was designed. This consisted of 5 factors. It is very popular with the prosthodontists. See, the first factor is condylar guidance. Condylar guidance we cannot modify in the articulator because it has to be provided by the patient. Patient's condylar guidance we have to copy in the articulator. So with our programming system, occasionally we find that nearly 5 degrees difference may happen. And if it is there, allow the condylar guidances to remain as such. And there is a tendency to make the average of both, but that is not necessary. Whatever the patient gives, we have to copy in our articulate. Next is incisal guidance. In incisal guidance, we have to program two things. One is the antero-posterior slope. That is usually limited to 10 degrees or less. Second one is side wings in the articulator. We have to adjust, and that is also limited to 5 degrees. The next factor is occlusal plane orientation. In the edentulous individual, the occlusal plane orientation is usually selected from maxillary incisal edge to midpoint of the retromolar pad. And initially, people thought that this can be raised up to 10 degrees, but that is not a practical suggestion, because whenever it is moved up, it can initiate forces that can tip the denture. So practically, we are not supposed to change the occlusal plane orientation. Then the prominence of compensating curve. And the compensating curve is incorporated to compensate for the Christensen's phenomenon, which we observe, especially the disocclusion in natural dentition. And how we get to this compensating curve? The method is the first molar, the distal half, and the second molar are tilted up to 15 degrees roughly. And there are templates also available to make this arrangement. 10, 15, 20 degrees templates are available. And this is adjusted by the operator. So we can adjust compensating curve, and it may become successful in providing balanced articulation. Now the cuspal angle. And this is a high cuspal angle, that is the 30 degrees. And in getting balanced articulation, it is desirable to reduce the cuspal angle to keep it up to 10 or 20 within that range. When incisal guidance is increased, when we program the articulator, these points should be taken care of. When the incisal guidance is increased, posterior disocclusion will occur. And this can be controlled by occlusal plane inclination changes, cuspal angle changes, compensating curve increase. These are the three factors, but limitation is for the occlusal plane inclination. Patient presents the condylar inclination and it cannot be changed. Occlusal plane cannot be altered substantially to ensure functional efficiency. Within the limits of aesthetics and phonetics, minimize the incisal guidance to minimize tipping forces generated in the denture. So these points we have to consider while arranging the teeth. Only cuspal angulation and compensating curve can be adjusted. So the cuspal angulation, if there is a disoccluding gap, a little increase in the cusp might provide balancing contact. Then compensating curve, if you make it a little steeper, then also you may get the balanced articulation. But always the incisal guidance should be limited to 10. See, this is the centric position achieved in a normally arranged denture. And in protrusive position, the incisors come into contact and we get balanced articulation in the posterior region. The teeth used belong to 20 degrees. Right side working position. See, here the working contacts you can see, and left side balancing position is this. So these are conventionally obtained with modified cuspal form. And from the beginning, anatomic occlusion has been considered as advantageous by many research workers. The advantages are it penetrates food more easily, resists the rotation of denture bases through cusp interdigitation, provides better aesthetics, acts as a guide for proper jaw closure because the cuspal slopes will guide the closure because we are arranging the teeth in centric relation. So there won't be any difficulty for the patient to find the intercuspal position. And normal anatomic form tooth provides better aesthetics also. But disadvantages also were listed. More occlusal disharmony during settling and difficult to correct by adjustment. Because if especially the mandibular denture settles down in due course of time, and that can initiate interfering contacts. Very difficult to adjust, and without thinking any consequence, people used to grind off. And with the anatomic form, horizontal forces are increased because the slopes will interfere. It is difficult to adapt to abnormal jaw relations, especially class 2 and class 3 relations. And in a non-anatomic teeth, advantages does not lock the mandible in one position because allows freedom in movement, permits the use of less time-consuming techniques. Arranging teeth is easier with the non-anatomic. Minimizes horizontal stresses because cuspal heights are less, so horizontal forces will not be generated much. Adapts easily to class 2 and class 3 jaw relations. More easily adjusted after changes in vertical and horizontal relations. See, during settling, the non-anatomic forms, modified or 0 degree, can get adjusted by themselves. Easier to arrange in crossbite. If you want to arrange a crossbite relation, that is possible with the non-anatomic forms. Disadvantages are also there. Poor aesthetics, because patients feel that it is all worn off teeth. Decreased masticatory efficiency, because if we are using 0 degree posteriors, masticatory efficiency will be reduced. Difficult to obtain balanced articulation. That is also, without changing the occlusal plane drastically, difficult to get balanced articulation. Psychologically, people are not ready to accept this. If 0 degree posteriors are used, we get balance from balancing ramps. But 20-degree teeth was a good solution for all of us, and we were trying that. Either we obtained 20-degree teeth, if it was not available, we have modified it. And this listing was given by Curtis M. Becker in an article on lingualized occlusion for removable prosthetics, Journal of Prosthetic Dentistry, 1977. Now the lingualized tooth forms. See, initially, the tooth form, lingualized tooth form was developed to adjust it to cross-bite relations. And this is the guys is cross-bite posterior teeth. And later French modified it, and he has made the lingual cusp contact the flattened maxillary posteriors. And then this was also termed as lingualized occlusion. But Payne actually changed the whole concept and formalized lingualized occlusion. Maxillary lingual cusps were to maintain contact with the mandibular teeth. See this. And at the same time, the buccal cusp will not be in contact. In centric, only the palatal cusp will make contact with modified or flattened mandibular. And for both working and balancing contact, only the lingual cusp make a contact. That is the specialty of lingualized occlusion. And this is briefly described in the article Phoenix and Engelmeyer, Lingualized Occlusion Revisited, JPD 2010. And the advantages of lingualized occlusion, it yields cross-arch balance, improves denture stability, enhances patient comfort. Lateral forces are reduced because maxillary palatal cusp provide the sole contact with the mandibular posterior teeth. So this palatal cusp can move freely on the modified occlusal surface of the mandibular teeth. That is the advantage. And the lingualized occlusion advantages are vertical forces could be centered upon the mandibular residual ridge. See, the modified or 0 degree, then palatal cusp are meeting the central fossa in centric. And we usually position the mandibular posteriors on the crest of the residual, mandibular residual ridge. Vertical forces ensure denture stability, maintain support in hard and soft tissues. Because the health of the residual ridge is maintained, especially the mandibular residual ridge, is reasonably maintained by this lingualized occlusal scheme. This is a simplified tooth arrangement, and occlusal adjustment is also simple. And masticatory efficiency is good because it efficiently penetrates the bonus. Aesthetics is not compromised much. So these are additional advantages of lingualized occlusion. Now the principles. Anatomic posterior teeth for the maxillary denture. We usually use. Some modifications are made only on the buccal cusp. Non-anatomic or semi-anatomic teeth for the mandibular denture. Either a shallow or flat cusp form is used. Maxillary palatal cusps should contact mandibular teeth in centric. That is shown here. Only maxillary palatal cusps make balancing and working contact. In the escursive movements also, only the palatal cusp makes the contact. This is working contact, this is balancing contact. Protrusive contacts between maxillary, palatal cusps and mandibular teeth. In protrusion also, the same posterior tooth makes the contact. See, this is the heavily modified palatal, the occlusal surface of the mandibular teeth. And here is the maxillary posterior tooth. The buccal cusp will not make a contact in centric. The palatal cusp is making a central force of contact. This is achieved either by modifying the buccal cusp or by tilting the tooth. It's angulation. And here you can see the working position. And this is the balancing position of both sides. And now some details on the lingualized occlusion. Teeth are arranged and usually a template of 20 degree is used to modify the teeth and arrange the positions. And this is the maxillary posterior teeth. See, the prominence of the palatal cusp is very evident, either by reducing the buccal cusp or by tilting the tooth buccally. This will engage the central fossa. See, this is the working side, and this is the non-working or balancing side. Now, certain research work done on bilateral balanced occlusion. The question is, does bilateral balance result in less alveolar bone loss? The Winter et al. Conducted a 5-year-long cephalometric study of 45 edentulous individuals for whom new dentures were made with either anatomic occlusion, semi-anatomic, or monoplane teeth. The anatomic occlusion group had significantly less resorption, that was their finding, than the monoplane occlusion group with the semi-anatomic group in the middle. So, least resorption for anatomic occlusion, next comes semi-anatomic, and maximum resorption with the monoplane occlusion. Anatomic teeth gave well-defined maximum intercuspal position, which might have resulted in less denture movement and horizontal forces. That is the reason they have raised why anatomic occlusion gave, in their observation, lesser resorption. More patient satisfaction will you get if balanced articulation is used. Different views give scattered results, with some supporting the concept of improved patient satisfaction with balanced articulation. Other literature concludes no difference between balanced and non-balanced occlusion in the matter of satisfaction. So, to improve satisfaction, balanced articulation may have limited role. So, patients may not feel much difference. Does bilateral balance result in better chewing ability? The literature presents weak evidence that occlusal scheme did have an impact on the participants' masticatory ability, because chewing ability also is not favored by bilateral balance. So evidence is not there. That is the problem. Alveolar bone loss, another study. There is some support for increased alveolar bone loss with complete dentures that have a non-balanced occlusion. So initially it was said that different forms of occlusion, But here, balance and the bone maintenance. Increased alveolar bone loss with the complete dentures that have non-balanced occlusion. So if it is not balanced, see, dentures will be destabilized and horizontal pulses will be generated, and that may cause resorption and especially mandibular residual ridge. And there is a consensus conclusions because the results obtained from various studies are different, and people started telling that balanced articulation is not necessary, especially in the post-dental implant era. And in one article, there is a consensus generated. The consensus are this. There is strong support that the average denture patient with good residual ridges and no neuromuscular problems will function adequately with a properly fabricated complete denture, regardless of the occlusal scheme. See, if the residual ridges are prominent, especially in class 1 and class 2, maybe the bilateral balance may have limited effect. There is neither strong support for or against bilateral balanced occlusal schemes in relation to patient satisfaction, preference, or chewing ability. So it is a neutral stand in the research. Another consensus conclusion is there is a need for bilateral balanced occlusal schemes for patients presenting with loss of stability and retention as a result of their presenting conditions. That is SEP classification 3 and 4, where the residual ridge, especially the mandibular residual ridge, is becoming flatter. So there, balanced articulation is essential. And the article in which the consensus conclusions appeared is by Gary Goldstein et al. Complete denture occlusion, best evidence consensus statement. Journal of Prosthodontics, April 2021. This is a good article worth reading so that you can take a decision whether you need bilateral balanced occlusion or not. We cannot see the wind, but we can feel it, and we know it is essential. Balanced articulation too is similar. Its effect we cannot prove beyond doubt, but it is essential, especially select cases. Thank you. Thank you so much.
Thank you, sir. Moderators can ask the questions.
There are no questions in the chat box. Over to Dr. Vidyasri Nandini, ma'am.
Thank you, Dr. Manju. So it was a wonderful presentation, sir. A challenging topic told to us in very simple way. This is reminding me of my postgraduate days where we used to sit and listen to you late in the evening also for all the presentations. In fact, there were no questions in the chat box. Probably they were awestruck that such a complicated topic has been explained simply. Sir, I have one or two questions, sir.
Please.
Sir, in lingualized occlusion, is there a chance of cheek bite because we have some spaces between the teeth buccally?
If the gap is more than 1 millimeter, that is between the buccal cusp of the maxillary posteriors and the mandibular. If it is more than that is 2 millimeters gap, definitely if we give, and the maxillary teeth are tilted buccally also, then the chances are less. Otherwise, there is an accidental chance for cheek belt. But a gap you give 2 millimeters. then it will be okay.
Yes, sir. So we have to maintain that gap, most important.
In Lingualized, that is the characteristic also. That is between the maxillary buccal cusp and the mandibular occlusal surface, there must be a gap of minimum 2
2
millimeters.
millimeters. So there is one question which has come up. Enter bolus, exit balance. What is your take on it, sir?
See, it was, we were making it a riddle in our student days also. But
It's an essay question also, sir.
that is, the question paper setter hasn't got anything else in his stock. That is why he has put that. But now it is not a relevant question. But I can tell you, we are positioning the teeth and such big bolus. Do you think the patient will bite and destabilize? No. But one thing is the lever balance, that is positioning of posterior teeth, will give, other than the occlusal balance, a lever balance also. So if lever balance is there, it will take care. So whatever the bolus that goes in, it will be crushed. And till the teeth come into contact, if the bolus is a little of some considerable size, the lever balance will compensate for most of the destabilizing factors. So there won't be any problem. Let the bolus enter.
So at the same time, the teeth also come in contact on so many other occasions throughout the day. So this balancing is supposed to help not just for the mastication, but throughout the day to keep denture stable.
True.
Yes, sir. Swallowing action.
Yes.
Bruxism. The 17-20 minutes contact. No, sir.
True, true.
So there's one more thing, sir. We give such carefully look at bilateral balanced occlusion, do all the grinding that is required during teeth placement. But after some time, teeth are going to be worn off.
Yes. True. That is true. Because
yes, sir.
The surface of the acrylic teeth, the surface portion will be nicely polymerized because it is in contact with the metallic mold. And that portion is ground off. So the weaker central region is exposed. That is why it is subjected to extreme wear. So I think if the new composite resin teeth are used, there may be some compensation. It may not wear off. Otherwise, moreover, let the teeth wear for some time. After 5 years, anyway, we are making a new one.
At the same time, after the corrections, if we polish, I think that may reduce the abrasion of the teeth and wear off. The occlusal surfaces have to be polished.
That's the core portion of the acrylic teeth are usually softer than the crust. Okay.
So then one more, sir, one last question, sir. Otherwise, I don't see any other questions in the chat box.
Okay.
What about class 2 situations, skeletal class 2? Because we cannot give them the regular balance, only ideal cases it's possible in class 1. So in class 2, how do we achieve it, sir?
In class 2, the balancing is mainly achieved at the expense of the posteriors only. That we can get. And it is almost easily achieved, but if you want a contact in the anterior region, you may have to augment the palatal vault so that mandibular incisors can make a contact, but that is not necessary. With the posteriors alone, the working balancing relationships we can get. But protrusive balance, that also only at the expense of posterior teeth. It is a little tough to get the anteriors to come forward and make an incision contact. But if it is a moderate class 2, that also we can get. Otherwise, along with the palatal vault, the mandibular incisor will come into contact with the palatal vault of the maxillary denture. That is in the anterior region. That is how we get.
So the teeth arrangement we can follow in the class 1 itself, no?
That we can, if it is not there, we will dispense one tooth. That is also possible. Now, class 1 relation is a very good stable contact. That is why we insist on that. But we may have to dispense with one premolar. That may be necessary. And in lingualized occlusion also, you might have noticed that all the teeth are not used. Wow. We usually sacrifice one set of premolars so that easily we get lingualized. Because the mandibular first premolar hasn't got a good quality lingual cusp. So when we are making it flatter, the morphologic details will disappear. So what we safely do is we remove that mandibular first premolars. All other teeth are used.
Actually, one more question, sir, in the chat box. Can bilateral balanced occlusion be achieved in extremely resorbed ridges?
We can achieve. We can achieve. See, I have told in one slide that where it is indicated, this bilateral balance. But only thing is, cusp height will be minimized. And moreover, in the implant era, these questions will not be a problem. Only thing is patient's affordability. If patients can afford, I think implants will answer many questions.
Yes, sir.
Okay.
So it was a wonderful, yes, Dr. Manju.
No, concluding remarks, Dr.
Yes.
Vidyashree.
Thank you. So it was a wonderful session, simply explained for all the students. I am sure they have all benefited the most now at this time. Even we have had some take-home points. Just to summarize the presentation, Sir has been very specific and simple on the importance of balance. He has given us the importance of balance for the stability of the dentures in complete dentures, how it is different from natural occlusion, about the Hanau squint, how 13 became 5, the various tooth forms, the various occlusal schemes, difference between natural and non-anatomic occlusion, and in detail about lingualized occlusion, which has always been a gray area. So I'm sure there are a lot of take-home points. I thank you, sir, for presenting this wonderful lecture. Also take this opportunity for inviting me here. I have to thank the organizers, Vishnu Dental College, Sajjan sir, his very great team, which has been functioning very well. Last time also they had a very good program. This time they've come up with balanced occlusion specifically. A very good topic for the present day students who are only thinking in terms of implants these days. So thank you all. Thank you the management and the team of Vishnu Dental College headed by Sir, Sajjan sir. You've done a wonderful job, sir. Thank you for inviting me. Thank you, sir, for your lecture. Yeah, I'm sure there will be a lot of thinking going on among the students.
Oh.
Thank you, sir.
Thank you, Dr. Manju and Dr. Nandini.
Thank you, sir.
Thank you, sir.
Thank you, sir. Nice, sir. Kindly accept the certificate, sir.
Okay, please.
Next. Yeah, next.
Dr. Manju, madam, and Dr. Vidyashree, madam, kindly accept the certificates, madam.
Thank you, sir.
Thank you. Thank you, sir.
Our next session will be by Dr. Rupinder, sir. Dr. Rupinder, sir, I should mention that we are very thankful for accepting such a challenge within a short duration of time. And this session will be moderated by Dr. B. Chalapati Rao Garu and Dr. Sumit Kumar Sharma Garu. Dr. B. Chalapati Rao, sir, has completed BDS from SDM Dental College, Dharwad, and MDS from RV Dental College, Bangalore. He is presently working as professor at Mamata Dental College, Khammam. He is also currently serving as EC member, Indian Prosthodontic Society. He is founder member of Indian Prosthodontic Society and first secretary at IDA Telangana State Dental Branch. In 2021, he has served as vice president for Indian Prosthodontic Society. Dr. Sumit Kumar Sharma did his BDS and MDS from SRM Dental College. He is currently working as head of the department in KIMS Dental College, Amlapuram. He has over 12 years of academic and clinical experience in the field of prosthodontics. Sir, kindly moderate the session, sir.
Yeah, Dr. Chalapati and Dr. Sumit.
Good morning, sir.
Very
Good morning,
good.
sir, Sajjan, sir. Thank you.
Good
Thank
morning,
you for
sir.
inviting and thank you for choosing.
Yeah, Sumit, you can take
Sir,
uh,
sir,
with
sir.
respect to introducing the Rupinder. Yeah, I
Thank
will.
you, sir.
I'll give a
Thank you.
concluding remarks. Okay, you can
Thank you.
introduce.
Thank you,
Yeah,
sir.
yeah.
Yes, sir. Yes, sir.
Mm.
Good morning, sir, Sajjan, sir. Very good morning to all the faculty members. It's an honor to be a part of this wonderful program. I welcome all the delegates as well as the students over here. I myself, Dr. Sumit Sharma, take an extreme privilege to introduce our guest speaker, Dr. Rupinder Singh Dhal. Sir is currently working as a professor at the Department of Prosthodontics at Himachal Institute of Dental Sciences in Himachal Pradesh. Sir is the director of UG studies at the same institute. Sir has started his career as whereby he did his BSc from St. Joseph's Arts and Science College, Bangalore. After that, he pursued his undergraduation from Ambedkar Dental College, Bangalore, and later finished his master's from College of Dental Sciences, Davangere. Sir is currently pursuing his PhD from Baba Farid University, Punjab. Sir is a diplomat and he has recently cleared the Part 1 exams from Indian Board of Prosthodontics. Sir is currently doing CCHP course. Sir has conducted over several CDE programs and has bagged many national and international awards. Sir is currently a postgraduate mentor as well as, and he has many international and national publications to his credit. Sir has been a modulator as well as a chairperson for many conferences. Sir has a total experience of 17 years of clinical as well as academic experience. We are fortunate to have you, a renowned person, for us to give a lecture, and I hope all the students as well as the faculty members will take some information which will help them in our day-to-day practice. I welcome you, sir, and I ask you to take over and continue the program, sir. Thank you.
Thank you, Dr. Sumit, for such a wonderful introduction. A small and the most important thing, it wouldn't have been possible for my teacher, my guide and guru, Dr. Sajjan sir, when I went on to do my PG under him in 2002. It's 20 years back. Thank you, sir, for giving me opportunity and Vishnu Dental College. I hope I justify with inputs given on such a topic, which is factor influencing the balance occlusion with Chandrasekhar Nair sir giving such a great input already. I would try to just justify and add up to little evidence, and especially with Sir Chandrasekhar Nair sir was my teacher in BDS in Ambedkar Dental College. So, all my teachers are there, and, I will try to keep their faith in me. And over to the lecture, you can play my, my presentation, and I'll answer the question at that time. Thank you so much. Thank you. Good morning, everybody. My name is Dr. Rupinder Singh Dhal, and I'll be discussing the factors influencing balance occlusion in CD.
This is just a memory of mine where I was receiving an award from a very known film actor. Everybody knows him, Raja Murad. It's been a great journey. So let's begin the presentation. The terminologies which are used are occlusion and articulation. So it's very important to understand these two terms as we build up, understanding the factors on balance occlusion. Occlusion is the static relationship between the incising and masticating surface of maxillary or mandibular teeth or tooth analog. On the other hand, articulation is both static and dynamic contact between occluding surface of the teeth during function. So what is the difference between natural and artificial occlusion? Since you'll be developing a bilateral balance occlusion in a complete denture, we need to understand the difference. The teeth in natural dentition are retained by periodontal tissue, which is missing once we extract the teeth. So the edentulous mouth receives its proprioceptive feedback from the underlying tissue and its pressure sensors which receive forces from the force of occlusion. So there are various concepts of occlusion. They basically fall into three categories: balance occlusion, non-balance occlusion or monoplane occlusion, or lingualized occlusion. These terms non-balance will be discussed because in monoplane occlusion, by giving balancing ramp, we can develop at least a 3-point contact and giving a occlusal scheme. But the overall concept of complete denture occlusion are under different headings: lingualized occlusion, monoplane occlusion, neutrocentric occlusion, organic occlusion, linear occlusion, physiologically generated occlusion, and balance occlusion. This discussion of the presentation is limited to balance occlusion. So let's go on to understanding this balance occlusion initially reported by Brewer. The definitions are very understandable by the term balance. Anything you want to balance, suppose I just give an analogy, like you have a table with 4 standing rods supporting it. Suppose I remove 1, still 3, but if I remove 2, the table falls down. Similarly, in balance occlusion, we require minimum 3-point contact, 1 anterior, 2 posterior. If you establish more, the balanced denture will be much more better stable. Okay, so the balance occlusion can be defined as bilateral simultaneous anterior posterior occlusal contact of teeth in centric and eccentric position. So in that, there are two sides, working and the non-working side, also called as balancing side, and they need to be having simultaneous contact, right? So Geisy in 1950 gave this simultaneous contact of maxillary mandible teeth on right and left side in both posterior anterior, in-centric and eccentric position, developed to lessen or limit the tipping or rotating forces of denture base in relation to supporting structures. This is a diagonal representation which is present in the natural teeth, where you can see that there is laterotrusive contact and mediotrusive contacts, which is something which is called as working and balancing contacts. So these two contacts develop lateral balance. So what is the difference between a occlusal balance and a lever balance? Now understanding these two words are very important because this will build up on the concepts which are proposed in balance occlusion. Occlusal balance. It is the bilateral simultaneous anterior posterior occlusal contact of teeth in centric and eccentric, whereas lever balance is the balance of complete denture depending on relation of the tooth position to the underlying denture supporting tissue. So if the ridges are more resolved, you try to bring the teeth closer so this lever balance is increased or the balancing is better and there is stable denture basis. So these are the two things which you need to understand in principles of balance occlusion. What is a greater balance and what is a poorer balance? Greater balance means when you have wider and large ridges, closer the teeth to the ridge, better it is. Teeth are placed lingual in relation to the crest of the ridge, narrower teeth buccolingually, and the more center the force of occlusion anterior posterior. When do you have a poorer balance? The smaller and narrower ridges, further the teeth from the ridge, as in resorbed cases, buccal positioning of the teeth sometimes encroaching on the space of neutral zone, and wider teeth. So what is the importance of balanced occlusion? Many people have tried to explain this. One of them was Prime, who gave the concept enter bolus, exit balance, which implies that introduction of food on one side will prevent the tooth on the opposite side from coming in contact. Hence, occlusal balance is impossible during mastication. But Shepard in 1964 later gave the concept enter bolus, enter balance. So this is very important. He said that the teeth cut through the bolus come in contact even for a few seconds, but still the stability of denture is maintained during various movement of mandible during chewing. Now the bilateral balance occlusion is more important during activities such as swallowing, saliva, closing to reseat the denture, bruxing of teeth during times of stress. So basically the role of balance occlusion comes during functional movement. And what are the advantages of it? It provides harmonious relation with surrounding stomatognathing system. Denture are stable during activities and cross arch stability is very much present. Lateral forces are present. These are the disadvantages of the balance occlusion. So we require special instruments since we need to record the centric, protrusive, condylar inclination by doing some records which are called as protrusive records to record the condylar guidance angle. And for them, we require transfer some special instruments which are called as placebo and semi-adjustable articulator, if possible, fully adjustable articulator. So what are the type of this balance? Unilateral liver balance, unilateral occlusal balance, bilateral occlusal balance, protrusive occlusal balance. Let's discuss one by one. Unilateral liver balance. This is present when there is equilibrium of base on supporting tissue, when a bolus of food is interposed between the teeth on one side and space exists on opposite side. It is more of a theoretical taught in colleges, but you need to know. So when do you get liver balance? Placing the teeth so that resultant force on the functioning side are over the ridge. Having a denture base that covers maximum denture bearing area. Placing the teeth as close as possible to the ridge and using a narrower buccolingual food table. Now, unilateral occlusal balance, it is present when the occlusal surface of teeth on one side articulates simultaneously as a group and with a smooth uninterrupted glide. So, how do you achieve it? It is present when there is equilibrium on both sides due to simultaneous contact of teeth in centric and eccentric movement. It requires minimum 3-point contact. I repeat, minimum, for establishing a plane of equilibrium. And some of the factors which are described to get this is called as Hanno squint, which we'll be discussing later. Protrusive occlusal balance. What is this? This is the most important thing in balance occlusion because Christensen gave explanation which is also called as Christensen phenomenon. When you protrude your teeth in natural dentition, there is a triangular space created in the posterior. We do not want an artificially generated occlusion. Why? Because we want anterior and posterior simultaneous contact. So it is protrusive occlusal balance is present when mandible moves forward, contacts are smooth and simultaneous on right and left posterior and anterior teeth. As you can see in this diagram, there is anterior contact and posterior contact when the patient protrudes from centric to edge, and it eliminates the Christensen phenomenon. So the various concepts proposed to attain balance occlusions started with 1914 when Geisy first gave the 33-degree cusp teeth. Cusp contact bilaterally to enhance the stability of denture, but shows deflective contact, extreme lateral movement. As we know that every cuspal incline has got its width. If you cross that width, the teeth will jump from one incline to another and the balance is lost. So the degree of movement to attain this balancing requires 3 or 4 maximum lateral or protrusive movement. That's when class 2 and severe class 3s, you cannot do anterior balance because in class 2, the amount of guide the teeth follows in anterior from its centric is around 6 mm or 5 mm by the time the cusp is glided from one incline to another. So we cannot do balancing in class 2 cases. That's the reason in exam, we have class 1 for MDS as a proper teeth case selection. Later, French in 1954 decreased the occlusal table width and lowered the posterior and sorry for this inconvenience. decrease the occlusal table width of the lower posterior, and while maintaining the balance concept. He developed a curved plane to attain the lateral balance, basically by giving, each tooth had a specific angulation, 5 degree for first premolar, 10 degree for second, and 15 degree for first and second molar. This article is very nicely given in JPD 1954. Later, CA proposed balance occlusion for non-anatomic teeth using occlusal plane which curve anterior-posteriorly. And even though they have plain occlusal, you can still give a compensating curve and create a balance in monoplane teeth. That's why that unbalanced thing which I showed in the beginning hold partially true if you do not give this compensating curve. Pleasure introduced posterior reversal lateral curvature except for second molar, which is set to align and arrange teeth in order to increase their stability. And finally, everybody knows Rudolf L. Hanau. He's the guy who gave 9 factors in 1926 that governs, which are called as laws of balance articulation. They were horizontal condylar inclination, protrusive incisal guidance, sagittal incisal guidance, sagittal condylar pathway, compensating curve, plane of orientation, buccolingual inclination of teeth, tooth alignment, relative cuspal height. Later, these 9 factors, also called, as I discussed, laws of balance articulation, reduced to 5, and this is what we discussed maximum in getting a balance occlusion: condylar guidance, incisal guidance, plane of occlusion, compensating curve, and relative cusp height. But Trapezano was not agreement with Hanau, and he reduced these to 3 factors. He eliminated the plane of orientation since its location is highly variable according to him within the available inner ridge space. He said the plane of occlusion could be shifted to favor weaker ridges. Weaker means those are resolved, require more lever balance, and the teeth can be brought down. Hence, its location is variable in intraspace. He also dismissed the need for compensating curve as he believed that these curves are generated automatically when cusp teeth are arranged according to the principle of teeth arrangement. This is the diagrammatic representation, which is also called as Trapezano's triad of occlusion from 1960 JPD article. Boucher in 1963 disagreed with Trapezano and proposed condylar guidance, incisal guidance, or orientation of occlusal plane as fixed factors. According to him, angulation of cuspal incline is more important than height of the cusp. The compensating curve is a device to increase the effective height of cusp without changing the form of individual teeth. This article is nicely given in 1960 JPD. Then came the lot concept, and he related the laws as follows. As you can see, it was basically to remove the Christensen phenomena, which he called unbalanced occlusion. He said the greater the angle of condylar path, the greater is the separation. The greater the angle of overwide, the greater is the separation in anterior region and posterior region. The greater is the separation of posterior teeth, the greater is the compensating curve required. The posterior separation beyond the ability of compensating curve to balance the occlusion requires plane of orientation change. So the greater the separation of posterior teeth, the greater must be the height of cusp. This is the diagrammatic representation. And finally, the Levin concept. Bernard Levin gave importance to 4 factors of Hanau's squint, and he called it as the quad. And he eliminated the plane of occlusion. In this is published in 1978 article, and this is what is the quad. He said that you can slightly change the plane of occlusion within 1 or 2 millimeter and to improve the stability. And this is the diagrammatic representation of the controlling factors of quad. Factors that affect balance occlusion by Hanau will be discussing further. Condylar guidance, incisal orientation of occlusal plane, compensating curve, and cuspal angulation. Now, condylar guidance, it is the path of condyle transversing the contours of the glenoid fossa. It is one of the end controlling factor, and it is independent of tooth contact. Inclination of condylar path, also called as first factor of occlusion, and you need to understand that the condylar guidance is something which is out of dentist control. This factor cannot be modified. What the patient has it. So this factor is recordable by doing the protrusive record during tracing, as we have learned in Gothica's tracing. to record that triangular space and the traversing of the condyle on the articular eminence. Now, this also, has rectilinear and curvilinear path, which is very tough to do on a semi-adjustable articular, which has a rectilinear path in its condylar guidance track. So even we try to achieve, we cannot replicate that curvilinear path until unless you create a customized condylar guidance track by recording the track in some medium. So this condylar guidance path follows the condyle in temporomandibular joint. Its significance is that it increase in condylar guidance will increase jaw separation. So a patient with 33° has less posterior separation than a 60 or 70°. So when the condyle goes down, there is more separation, the triangular space is more. We need to give more steeper curve, more compensating curve to accommodate this and reduce this to simultaneous contact. In patient with steep condylar, incisal guidance should be decreased to almost 0.5 degrees to reduce amount of jaw separation. This is the diagrammatic representation. As you can see, the condyle moving forward and the condylar track. Now, this condylar track is rectilinear, but by nature, we have a pathway like this. So, results from the shape of bony contour of TMJ and a tan muscle, muscles attached to mandible, limit imposed by ligament and its definite anatomical concept. Condylar paths are peculiar to each individual, and the dentist has no control over horizontal or lateral inclination. Recorded by taking protrusive record and then adjusting the articulate according to this record, as I discussed. Now, this is just a movement of the mandible forward. How does it move? Now you can see anterior guidance causes posterior, and there is space created in the natural dentition. We don't want, and this is how we control it. And this is the Frankfurt horizontal plane. This is the crust of the glenoid fossa. This is the articular eminence. And when the condyle moves downward, even though the red line shows curvilinear, we draw a line, and this is the condylar guidance angle, which is recorded. Now, what are the components of a condylar guidance? There are two, horizontal and lateral. Horizontal condylar guidance guides the forward movement of protrusive for protrusive balance. Lateral condylar guidance guides the sideward lateral movement of the mandible, which we know that, when the Bennett movement occurs and there are immediate side sheet, progressive side sheets, all these factors really control the contact which occurs in the denture basis. And since the denture bases are mobile on the underlying tissue, there is some kind of forces generated and the movement of the denture basis. But our idea of doing teeth arrangement is to have simultaneous contact, even though with the movable basis, denture basis. Next factor is incisal guidance. It is influenced by the contacting surface of the maxillary and mandibular teeth. Mandibular contacting the palatal surface. So it is expressed as the degree of angulation from the horizontal plane by a line drawn in the sagittal plane between the incisal edges of maxillary and mandibular incisor when closed in centric. And they produce two components, horizontal component called as overjet and vertical called as overbite. Dentists can set this in accordance to aesthetic and phonetics during trial of anterior during teeth arrangement. Even though you're given a shallow anterior guidance on the teeth arrangement, during teeth arrangement for doing balancing at anterior trial, you can adjust this. If the incisal guidance is steep, it calls for steep cusp and steep occlusal plane and a steep compensating curve to affect occlusal balance. For complete dentures, the incisal guidance should be as flat as as aesthetic and phonetics will permit. And as the teeth moves, these are natural teeth to show how it moves. This plane of palatal in nature is prevented, is not present in artificially because we are trying to give overjet and overbite to reduce this anterior locking of the anterior and posterior separation. So this is the analogy. What is present here, we try to give by giving this angle by customized, adjustable or mechanical incisal table. So what are the components of incisal? We discussed already, but horizontal and vertical component. What are the effects? So if the vertical is high and no overjet, there is steep incisal guidance. But if vertical and horizontal both are equal, we get a medium incisal guidance. But if the overjet, like in class 2, is there is shallow incisal guidance. And this is the influence of horizontal component and vertical component. So if overjet is increased, the inclination of incisal guidance is decreased. If the overbite is increased, the inclination of incisal guidance is decreased. So when the arrangement of anterior teeth necessitate a vertical overlap, a compensating horizontal overlap must be set to prevent dominant incisal guidance from upsetting the occlusal balance in posterior teeth. Next, inclination of occlusal plane. This is the factor which is adjustable but within limits. What is this? Inclination of occlusal plane. It's an imaginary surface which is related anatomically to the cranium and which theoretically touches the incisal edge of the incisor and tips of the occluding surface of posterior teeth. And it represents the mean curvature of the surfaces. It is mean curvature. Remember, it's not a flat plane, it is a curved plane, both mediolaterally and anterior-posteriorly. Even though we record it on a occlusal rim by taking a Fox plane, but when we do teeth arrangement, we create a curve, and that is exactly actually the occlusal plane. It's not a flat plane, it is a curvature. So the plane of orientation is established in the anterior by the height of lower cuspid, which coincides with the commissures of the mouth, and in the posterior by the height of retromolar pad. And its position can be altered only slightly by taking these two into consideration. This is a diagrammatic line diagram representing a position ABC of plane of orientation. A is the alar tragal plane obtained from the patient. This one, A. This is the actual plane which you got, alar tragal plane, campus plane. The B is the compromised plane in between the ridges, and C is the low plane when we require to lower the liver, lower the forces and increase the liver balance in resorbed ridges. The plane of occlusion can be altered maximum to 10 degrees. However, locating occlusal plane is high or low to favor the weak ridges. Weaker of the two ridges can interfere with neutral zones, so it should be done with caution. The compensating curve. The word itself says compensating. What does it compensate? It compensates the triangular space which is created by nature during natural teeth when they come, anterior teeth come in edge-to-edge contact during protrusion. That triangular space needs to be removed in balanced occlusion, especially in protrusive balance. To compensate, we give these artificial curves in the teeth arrangement. So it is one of the most important factors in establishing a balanced occlusion. Compensating curve or artificial curve introduced into the dentition in order to facilitate the production of balanced occlusion. They are the artificial counterparts of curve of P and monsoon that are found in natural dentition. Now this is the curve of Wilson, which is mediolateral curve. As you can see, it is present. If a line is drawn through the buccal and lingual cusp of posterior teeth, both right and left, a curve of plane of occlusion will be observed. This curvature is convex in maxillary arch and concave in mandibular. This compensating curve which are given have two dimensions, anterior, posterior and mediolateral. So we have artificially developed curve in both anterior position to create this curve plane, and mediolateral by giving the teeth this tilt during teeth arrangement. And these curves allow the dentist to alter the cusp height actually without changing the form of manufacturing tooth. So you can tilt, you still get a curve without changing the cusp height. Cusp can be made steeper or flatter simply by changing the inclination. The best thing is even 0 degree or monoplane teeth can have the effect of inclines or equivalent of a cusp by incorporating compensating curve, and you can give balancing ramp and AP curve by giving some balancing in monoplane teeth. So anterior posterior curve, the curve of P. This is the curve which starts from the tip of canine, premolar and molar, which goes back. And this curve which is present, it is an ideal curve aligned so that the continuous, it forms a 4-inch radius or 8-inch diameter sphere, which is spherical theory also, where the center is lying at glabella. So let's understand, these are beautiful diagrams. Those students who or the faculties who need, this is from HBR Fenn, who has tried to give a very simple explanation by line diagram. If we have a flat condylar track or inclination, there is no curvature, and the jaw moves forward, the occlusal limb forward, there is absolutely no problem. The contact is maintained. But what happens is, in nature, we don't have a flat, but there is an angle. So that when the mandible moves downward, there is a triangular space created posteriorly, this Christensen phenomenon needs to be eliminated in teeth arrangement. How do? We do by giving compensating curve. These curves will help in from centric, a protrusive, not so extreme, but there will be contact from here to here when the mandible moves down. Same way, mediolaterally, if you have one simultaneous contact, there are three curves which are present. In molar, this is called molar curve. In second premolar, it's flat, and in first premolar, palatal cusp up, it is called as anti-monsoon curve. So monsoon curve and anti-monsoon curve, they are given to remove this. See, if there was flat and that patient moves, the the balancing condyle will come down. There will be separation here, but we don't want that. We want even balancing in both mediolateral movements. So what happens is we give mediolateral curves. So when the jaw moves even in lateral direction, there is simultaneous contact. This simultaneous contact in both protrusive and lateral is maximum achieved by this curvature given artificially by compensating curve. And if there are interferences, they are reduced by doing selective grinding, right? And the most important, cuspal angulation. Each tooth has got, dental tooth has got its cusp, and this cusp angle is inbuilt in them. That's why we have, earlier concept 0 degree, semi-anatomic, anatomic 33 degree. So the angle made by an average slope of a cusp with a cusp plane measured mesiodistal or buccal-inglis cusp angle. So you can have mesiodistal cusp height that interdigitate and lock the occlusion, thus settling the basis of basis cannot take place. They get locked, too much. To prevent these, mesiodistal cusp height should be eliminated. Only buccal-ingular incline needs to be considered for balance occlusion. So these are done by selective grinding. And these are the inner inclines of the teeth which are ground during balancing and working side contacts. It's not part of this presentation. Those are different. You can see the mesial incline of the mandibular teeth articulate with the distal incline. So when the patient does protrusion, these are the interfering contacts which have to be eliminated. So all the 5 factors of balance occlusion interact with each other. The dentist can control only 4, as I told you, because condylar path is fixed by the patient, by the nature, by the God. We have no control over it. We cannot modify it. Incisal guidance and plane of occlusion can be altered only slightly, as we discussed. The important working factor for the dentist is to manipulate are the compensating curve and the inclination of curves on the occlusal surface of the teeth. And this is the summary, which is, Hanau's quint, which he made this by saying each factor, if you change, how does the other 4 factor needs to be adjusted, right? The height of curves, the prominence of the compensating curve, the inclination of the condylar guidance, inclination of the plane of orientation, the inclination of the incisal guidance. To summarize this, Thielman developed a formula, and he said if you multiply condylar guidance into incisal guidance divided by cusp height of inclination of occlusal plane and curvature, they interact with each other in such a way that if you increase one, the other needs to be compensated. And this is a balancing beam principle where incisal condylar guidance are on one side and the cusp angle and the occlusal plane and curvature, these 3 and these 2 control each other to develop the balance. So can you do balance in non-anatomic teeth? I've been telling yes, you can. And there are 2 ways. One is either to set the teeth in compensating curve as it done in anatomic form. So you'll get a simultaneous, as I showed in diagrammatic representation, or one can set the teeth in a flat plane and utilize a balancing ramp just distal to second molar. This ramp is adjusted so that the upper second molar will contact in eccentric movement and thus prevent, tipping by providing 3-point contact, which is the minimum for a balance occlusion. So these balancing ramp are developed in second molar either by, you can see in this diagram, you can put amalgam and ask the patient to do actually the movements and record it. And this article is very nicely given in by Richard Noble in 1958. Or you can do, something called as functionally generated path also and develop those contacts in the denture. So finally concluding, after discussing the balance, factors of balance occlusion, biologic, physiologic, and mechanical principle need to be considered and carefully coordinated in man-made occlusion. So we are the guys who give. It's artificial occlusion. If it is present in mouth, it is pathologic. Where is it there? It is present in Bruxer when they have generalized adhesion, all the teeth contact. Apply all of the factors that favor the stability of the base and design the occlusion to function optimally in relation to forces of mastication. Denture and its supporting structure will not be tolerated unless the occlusion established accommodate their idiosyncrasies. In such cases, balanced occlusion is imperative. And with this, thank you for listening and giving an opportunity to speak. And thank you so much. Thank you, everyone. Thank you, all the people. Thank you so much.
Yeah, Dr. Chalapati.
Yeah, sir. Very good morning to everyone. Thank you, Sajjan sir, and all the faculty of the Vishnu Dental College for giving me opportunity to moderate this session. Yeah, Rupinder, it was very nice presentation indeed.
Thank you, sir.
I have again, probably you also mentioned about the coordination between all these 5 factors,
Yes,
especially the condylar guidance, incisal guidance, occlusal plane, and inclination and compensating curves. But still, as you also mentioned, still I feel that apart from the condylar guidance, which is supposed to be understood as a fixed factors, but other incisal guidance and occlusal plane,
yes,
as especially even the Bocher or the Tropezano or the Bernard-Levin, those people also given a much importance to
yes,
the occlusal plane rather, again, which is not to be, you can say, corrected or which is also to be understood as a fixed factor.
yes, sir.
So,
Because as we know, aesthetic failure occur of change in plane only, sir. 2 down, 2 up. You have a denture with no aesthetics.
because that needs to be understood by all the postgraduate students, that in establishing the occlusal plane, when you are doing the registration of the jaw relations, plays a very important role in order to achieve the balance. Because otherwise, you will go wrong in ending up with the registration of the condylar guidance, and of course, in way again, I can say incisal guidance also, especially the overjet and overbite what you provide.
Yes.
So that's why the students has to understand the occlusal determination and your Facebook transfer primarily plays in a very important role in order to achieve the balance. That's what I would like to say, sir. Sajjan sir, anything?
No, if there are any questions from the audience.
There is no chat box actually. Nobody is probably still they don't know, I think, sir. So probably there might be starting with the balancing. So they know only theoretical aspect, I feel, sir.
Yeah, that's great.
Yes, sir.
Dr. Rupinder
Yes,
for
sir.
making this to happen in a very, very short time. I just gave him
Yes, sir. Yes, sir. Kudos and good applause to Dr. Rupinder, sir, for short time, probably. Yes, sir.
So this is one thing I've learned from Sajjan sir since my PG days. Once anything comes from Sajjan sir, it has to be done. And there's no, sir. We have never learned to say no to sir. If he says done, it has to be done, sir, at any cost, anyway. So in the night, I recorded. Some mistakes have occurred because I was trying to record. Sorry for that. But one thing I tell you as a PG students, there are techniques of doing balancing, which is not part of this, but there are 2 techniques of doing balancing. One, they do individual, one by one. I follow a technique since my PG days, which is given Neil and Narayan, where I do, all the teeth together and then start balancing all the 28 teeth in both centric and protrusive. It's a very nice book, small book by Neil and Narayan. PG students should read it, how they do the simultaneous balancing, sir, not individual teeth. So that I've been doing for almost now 17, 18 years since completion. And I think that will be
even I am hearing for the first time, probably, Rupinder. if you can share your mail ID, probably if you have any
Yes, sir.
soft copy of the textbook.
It's one of the books
probably
very much available in Davangere, sir. Neil and Naren. Sajjan
Neil
sir.
and Naren.
Yes, sir. Neil and
Okay.
Naren. So that's
Okay.
one very small book where they show
Okay.
simultaneous balancing, sir. You know, it's
So,
very.
nowadays, most of the postgraduates are in contact with Davanagare's library. Probably even I'll ask my PG students to get that book, sir. Yes, yes. Okay. Thank you, Rupinder. Okay. It was indeed my pleasure also to moderate the session in front of all the big personalities like Sajjan sir and my dear friend Secretary Shesha Reddy also, and at the same time, all the faculty of the Vishnu Dental College for giving me opportunity. Hope all the postgraduate
chance to speak, sir. Thank you so much, sir.
Yeah.
Thank you. Thank you.
Here you can receive your certificate, Rupinder, for doing the presentation. Thank you, Rupinder, again once
Thank you.
again.
Thank you so much, sir. Thank you, Dr. Sajjan sir and Vishnu Dental College for giving me an opportunity. I hope I fulfill my, justify what I presented actually. Thank you, sir. Thank you so much.
Thank you.
Second.
Yes, sir.
Chalpati
Thank you.
sir, kindly accept the certificate, sir.
Yeah, thank you, thank you.
Sumit, kindly accept the certificate, sir.
Thank you, ma'am. Thanks a lot.
Thank you.
Thank you, Dr. Chalapati and Dr. Sumit.
Yes, sir.
It was so
Thank
happy.
you, sir. Thanks a lot. It was an honor to be a part of this prestigious program. Thanks a lot, sir.
Thank you, sir, once again. Yes, yes. Yes.
Our next session will be moderated by Dr. Ravishankar Y and Dr. R. Prakash sir. Dr. Ravishankar Y sir has completed BDS and MDS from SDM College of Dental Sciences, Dharwad. He is currently working as Vice Principal, Professor and Head of the Department of Prosthodontics, Geetham Dental College and Hospital, Vizag. He has over 22 years of teaching experience till date. He was organizing secretary for 16th IPS PG convention held at Visakhapatnam in 2014. He is also a member of organizing committee of 24th, 39th and 43rd IPS conferences. He worked as president of Indian Prosthodontic Society in 2017 for AP State Branch. He is also vice president of IDA AP State Branch in 2015. In 2016 and 17, he is the president of IDA Greater Visakhapatnam. He has served as editor for IDA AP State Dental Journal for 2 terms and has been awarded with Editor Award at 64th Indian Dental Conference, Jaipur 2011. He is also a journal coordinator for CDE program conducted by Dr. NTR University of Health Sciences from 2011 to 2016. He worked as chairman for UG Board of Studies in Dr. NTR University of Health Sciences 2017 to 19 and member for UG Board of Studies Dr. NTR University of Health Sciences 2021 onwards. He is the present EC member of Indian Prosthodontic Society. Dr. R. Prakash sir did his BDS and MDS from Annamalai University and currently working as professor and head at Anil Neerukonda Institute of Dental Sciences, Visakhapatnam. He is a key opinion leader for international manufacturers like Sabre Dental UK, manufacturers of Curer Anchor System, Garrison Dental Solutions USA, popular for their range of sectional matrices, and Temrex Corporation, popular for their rigid autoclavable trip-in trays. He is a reviewer for the Journal of Dental Education, the official publication of American Dental Education Association. He is also a member of PG Board of Studies, NTR University of Health Sciences, and the editor of Indian Dental Association, Greater Visakhapatnam. Sir, kindly moderate the session, sir.
Yes.
Welcome, Dr. Ravi and Dr. Prakash. It was very nice to have you people on board. Please go ahead.
Thank you very much, sir. A very good morning to all the teachers, faculty members, and the postgraduate students who who have joined this program. It is a very much needed program because this is a part and parcel of the exam where you have to perform and you have to clear and do a better job and go. For that, you need to hone your skills of balancing, which cannot come just by doing one or two. You need to continuously practice. And till now, what lectures were told by Nair sir and our Rupinder Singh Dal and our own Dr. Suresh Reddy Sir will be giving you much more insight. It is not the theoretical aspects. It is the translation of the theory, whatever you had accumulated into practice, will definitely make sure that you're going to learn balancing. I take the pleasure of introducing Dr. Suresh Reddy Sir, a renowned educationist, a well-known personality in prosthodontic circles, and a very caring, kind-hearted, helping personality, and a mentor to most of us. Dr. Suresh Reddy Sir has completed his undergraduation from Bapuji Dental College, Davangere, Karnataka. Then in 1989, he pursued his MBA in Healthcare Sciences in 2008. He is Associate Fellow of American Academy of Implant Dentistry. He is presently working as the Principal and Head of the Department of Prosthodontics, Vishnu Dental College, Bhimavaram. He is recognized PhD guide in prosthodontics by Dr. NTR University of Health Sciences, Vijayawada. He is certified prosthodontist for DTR using T-scan. He has more than 100 publications in both in national and international journals. He has received funding from DST, Department of Science and Technology, Government of India, New Delhi for 2 projects. He has received a recognition award for outstanding contribution to regional branch of IPS 2001. It is a pleasure for me to talk about Dr. Sajjan sir. Whatever I told is very less. If you know him personally, these things are nothing. His personality and his way he approaches us and the way he treats us is more than whatever I talked about him. It's so nice, sir. Thank you for asking me to moderate your session. Thank you very much. I'm honored, sir.
Thank you. Thank you.
Sir. Over to you, sir. Thank you, sir.
Namaskaram to all of you. Good morning and greetings from Vishnu Dental College. Before starting, I would like to thank Indian Prosthodontic Society, Andhra Pradesh and Telangana, and Indian Prosthodontic Society at the national level for giving me an opportunity to present this topic here. Well, this is greetings from Vishnu Dental College. This is located in West Godavari district of Andhra Pradesh. I welcome you all to visit our institution. Myself, Dr. Suresh Sajjan. I'm principal of Vishnu Dental College. Now let us go through this topic for today, that is stepwise approach in achieving balanced occlusion or articulation to say in proper in a completely edentulous patient. Okay, what's the relation between this picture? It's not about balanced articulation, but it is about thinking of the students. You'll be happy to see this kind of one if it comes as a question for you in the exams, because it looks pretty simple. But you need to think slightly out of the box, then you can answer well. It is like you see one of this bird is looking in a different direction, so it might get a better fish than all of them going in one direction. Well, what is this balanced articulation? As according to the GPT-8, it was mentioned as bilateral simultaneous anterior and posterior occlusal contact of teeth in centric and eccentric position. Now CP Owen, the defined it as a continuous contact of as many mandibular and maxillary artificial teeth as possible in all excursive movements away from and into the position of maximum intercuspation. This sounds more appropriate, and there was a change in GPT 8, that is, then it changed to the bilateral simultaneous occlusal contact of anterior and posterior teeth in excursive movement. Now you need to see and compare between the GPT 8, where it is said centric and eccentric positions. Now it is only excursive movement. It means that in centric relation or centric occlusion, the anterior teeth need not be in contact. That is one of the things that is changed. So during eccentric movements, only there should be continuous contact. That is more important. Well, what is the clinical significance of this balanced articulation? Because it was acknowledged as back as 1962 by Joseph Landa. He also mentioned an interesting point that we don't give enough importance to occlusal corrections. That's what he mentioned at that point. Because he thought about this to have it as if the teeth don't remain in contact during the other functions, that is more important, not just while eating, because the teeth do come in contact at a lot of other times, while drinking, there maybe sometimes during speaking and other things, where we tend to swallow the saliva in the whole day so many hundreds of times. So each time the teeth come in contact, the denture need to be in stability. So that is very important. Now another thing that we have to keep in mind here is whatever the occlusal corrections we do while doing while establishing the balance at the final stages, then the surfaces should be polished. That is very important. Otherwise, if there is a roughness, then there will be a friction between the teeth and there will be a abrasion of the teeth very fast. So to avoid that chance, always whenever you're trying to do any occlusal corrections, after occlusal corrections, whether it is a natural teeth or the artificial teeth, always polish the surfaces. Okay, that's very important. Now the balanced articulation has 3 points that has to be kept in mind while achieving. The first thing is bilateral simultaneous contact of the teeth. Whenever there is a movement from centric to eccentric, there should be a smooth glide. There should not be any interferences. And it is also in harmony with the temporomandibular joint and neuromuscular control, because as the teeth move because of the movement of the jaw, so there should be a harmony in there. Otherwise, the harmony is the teeth might affect the temporomandibular joint. So that we have to keep in mind always. Well, you must be well versed with this formula that is given by Thielman as the Condylar guidance. So to call it as a balanced one, he put it like a real physical balance, keeping the condylar guidance and the incisal guidance on one side, and the occlusal plane or the orientation plane, then the cuspal inclination and the compensatory curves on the other side. Okay, so because each one are dependent on each other, you would be hearing about it. You must have already learned about it in the different factors affecting the balanced articulation. Well, Hanavu was not a dentist. He was an engineer. He designed the articulator that we are using most popularly in India. Okay, So just as have a small quiz before I go into the next part of it. Now, can you tell me what is going to affect what is there as Hanau quint? It consists of 5 components which are commonly used in creation of the balanced articulations. Now, it includes it has all the 5. Now, which one is not part of his quint? Okay, condylar inclination, cusp height, incisal inclination, lateral translation, occlusal plane orientation. Just to give a small break to you. All right, it is the answer D. So whoever thought about the lateral translation is not a factor of balanced articulation. It is part of the balanced articulation. It does not influence. Okay, so let's go further. We are all aware of the steps that are used for making the dentures. Now, there are clinical steps and there are laboratory steps. There are so many laboratory steps that we follow and the clinical steps we follow in order to establish good complete denture. Now, what we have to remember here is the complete denture, when it is balanced, to have favorable prognosis for this complete denture, it is very important to keep in mind that it is not just the articulation that provides stability. Rather, I would say the balanced articulation maintains established stability. It does not allow the denture to lose stability rather than it itself provides stability. That is how we have to think in. So, if we have to establish the stability before having the balanced articulation, we have to keep so many other things in mind. Now, in making complete denture, whether we do it in the digital form or whether we do it in the normal conventional form, it would be important for every step that we follow. So, even though the digital dentures are coming, it is not that the digital is going to replace. At this moment, we are still having several issues with the digital dentures to make them. So we still depend on the conventional steps to a large extent, and then we can digitalize it. Well, now when we are doing the conventional dentures, as we commonly do, because we are well versed with it, so clinical steps we follow right from diagnosis to follow-up, and the laboratory steps again start from diagnostic models, and we have to end up with the clinical remount. So every step is important. I'm going to take you stepwise into these areas so that we can end up in a denture with the balanced articulation. Okay, so that is what my objective for this presentation. Okay, so let us see in the first step, if we are thinking about balanced articulation to provide the patient with balanced articulation. It's not that every patient we can do balance. Now the balancing has 2 components. There is a protrusive balance and there is a lateral balance. Now if it is anything other than ACP class 1 or class 2, basically class 2, then the class 3 and onwards, the ridges are poorly formed. They may not be able to sustain the movement of the denture or the lateral forces that are exerted because of the inclinations of the cusps. So we try to keep the cuspal inclinations as flatter as possible, and still we can establish a balance, even though not protrusive, but at least the lateral balance is very important according to me to establish, even if there is a poor mandibular ridges, because it is also like we use the lingual occlusal concept, where it also has some amount of balanced articulation concept as part of it, even though we try to tilt them a little bit to get the lingualized occlusion and direct the forces along the ridges. Well, now basically the conventional or normal balancing, the patient need to have a straight profile, means the ridges should be in a class 1 relation, and we need to have sufficient inter-ridge distance, about 19 to 22 millimeters, so that we can maneuver the teeth with comfort. And also the patient should have a good neuromuscular control, because to record the eccentric jaw relations, we need to have a good neuromuscular control by the patients. Otherwise, it may be difficult. So these are the first basic things that we have to keep in mind, other than several things which could affect the conventional denture making. All right. So the second step that we follow is impressions. Now we need to give very much of an importance to the starting point of making the impressions. Now it is always good to have primary impressions and error-free impressions. Please do not think that if we make this is a primary impression, I can make errors, I don't need to record complete, or if there is an exposure of the tray, it's fine, I can always take care of it in the final impressions. No, it's not that way that we have to think it. It always have to be making a good impression. Saves a lot of time when you are trying to prepare a special tray, and also when we are trying to make the impression. If we are able to prepare a good special tray on the cast, we can save a lot of time trimming it in the chair side, and that lessens your working time. It saves your chair side time, it saves the time for the patient, and your procedure can be speeded up much faster. So give a lot of importance to the preliminary impressions, and then prepare a good diagnostic models. The diagnostic models shall be of no air bubbles. That is very important. Well, as we make the special trays, the trays should be distortion free, so you have to follow the manufacturer instructions for the kind of material you are using, whether you use a normal or denture based material, or you use light cure or heat cure or thermoplastic, whatever. So follow the instructions carefully so that there will not be any distortion, and a good border molding and error-free final impressions are also very important. Okay, so this is just an example of good impressions where there is no exposures, and here we have used the putty and relining for the using light body for the preliminary impressions, and using the light body for making the final impressions. So introduction of the rubber based material has made our life much simpler. Well, we need to have the stable basis for to start with. That is very important. So the step 3 is jaw relation recording. Now here it is verifying the stable basis. Preferably a heat cure basis are good for the stability, because they will just be reflection of the actual denture seating. So when we are making a temporary basis, we have to block the undercuts in the cast so that the cast doesn't get damaged, and so on and so forth. So all those areas would make the temporary denture base a little not well adapted to the tissues. So if we are having a heat cure basis, that can resolve that issue to a large extent. Now, having a basis of permanent basis, and also see that there are no defects in this, no sharp edges or air bubbles in there. or the blown out nodules, because it's very important to have them without any defect so that they will be very comfortable to the patient. So you can also gives an assurance to the patient about how much retentive these dentures would be. So just be careful with the record bases, because they play a very important role when you are recording the jaw relations. Now, recording the jaw relations, you are well aware of the steps. I'm not going to discuss much about the steps because you are already knowing about it. Now, the order of establishing the jaw relation generally goes with establishing the plane of orientation, then establish the correct vertical relation, and then establish a centric relation, and then record the centric relation. Now here the orientation relation, which is supposed to be transfer of the orientation plane from the patient to the articulator so that the articulator can behave like a patient. Now that has to be that can be done either immediately after establishing the orientation plane, and or we can do it after recording the centric relation. Now it's not important when you transfer, but it is important to maintain the occlusal rims intact after the transfer so that the centric relation can be mounted very well. So that is very important for us to do the centric relation and then recording eccentric relation. Now let us see a little bit about it. Now when we are recording the orientation relations, we are going to use the face bow and see that the patient is sitting upright and having the interpupillary line parallel to the framework. So that tells about the correct positioning of the face bow, and check for the midline. That is very important. Now where we also have to be very careful is transferring or removing it from the patient's mouth. If while removing the patient's mouth, never touch the locking mechanism or the joint, because the moment we touch the joint, there is always a possibility of changing the position. So just hold the fork as you see in the picture, and you can remove it from the patient without touching, and then put it on the articulator. You can either choose the direct mounting or the indirect mounting. Please don't combine them together, so that you will have a correct relation that is transferred to the articulator. That is very important. So you can, as I said, you can do it at 2 stages. Either before recording the centric relation, you can record the face bow, mount it to the articulator, and then go back and record the centric relation and then mount the mandibular. Or you can record the centric also and then separate the occlusal rims. There will not be any issue if we are using the good locking mechanism other than using the staple pins or sealing using a hot knife that used to be practiced some time back. When we are using things like nick and notch technique to lock them in position, it's very easy to separate and reorient them back in the recorded relation. So you can do that, and then you can record the face bow transfer and then send the patient, then you can mount and then come back to the your occlusion planning. Okay, when we are trying to record the eccentric relations, this is one important thing from the exam point of view, because positioning of the centric bearing devices is very, very important for the stability of the mandibular occlusal rim in the patient's mouth while recording, because if it is not positioned correctly, then there is a possibility of tongue may push it, and it is the only point that will be in contact with the maxillary occlusal rim to maintain the vertical as well as the stability. So we need to be very careful in positioning it. Generally, the guidance that is given by Hartwell was to draw 2 lines connecting the canine to the molar and connect to the molar on either side, and where they cross each other to put the whole of the mandibular or the lower arch centric part of the centric bearing device. So if we position that, it may look little bit positioned anterior, but it also prevents the tongue from lifting this. Otherwise, what can generally happen is if you place it more posterior, tongue is very thick and broad in the posterior region. So as you are trying to record, move the mandible forward, the tongue might push the denture base up, and then instead of the compensatory phenomena there, that is the Christensen phenomena to happen with the posterior disocclusion, to have more thicker space in the posterior and thinner space in the anterior, it might just get reversed. And when it gets reverses, you will have reverse readings also, and you will be wondering why my readings are coming in negative. Okay, so you need to be careful to position the centric bearing device and assure to have a stability. Then you can ask the patient to move the mandible and establish the arrowhead for the protrusive and the centric and the eccentric records. So make it to move only about 6 millimeters. Don't let the patient to do as far as he can. Then it will be an issue while you are recording them. So record just about 6 millimeters in protrusive. We do not really need to record the right lateral and left lateral, because it is not transferred to the articulator, especially when you are using the Hanav articulator. Okay, so as we go to the programming, it is very important. Here, if you have done or following the split cast technique for the maxillary, it might make it easier once you have recorded the protrusive. You can put a thread and seal it off or lock them up, and then we can see the positioning on the split cast. So that is one way we can program the articulator, make the programming the articulator very simple. Otherwise, there is a possibility of occlusal rims. They are made of wax. They might move or get compressed. So we can be using the simple technique to make our life better. And then while programming the articulator, we need to loosen all the screws, put some oil so that they can move freely, and establish the desired angle, what is there in the patient. So there are horizontal condylar guidance and the lateral condylar guidance angles to be fixed, and the formula that is given by Hanav is L is equal to the lateral condylar guidance is equal to horizontal condylar guidance divided by 8 plus 12. So invariably it will be more than 12 when we are recording when we are programming the articulator for the lateral guidance. Well, we may not be able to do protrusive recording using the mounting plates and all that. It may be a little difficult to do in a day-to-day practice, but it's always easier for the patient to, while we have the patient for the anterior arrangement try-in, at the same time we can also record the protrusive because we have established the aesthetics there, the overjet, overbite, everything will be established, verified. So taking that as a standard, we can ask the patient to protrude or close the teeth in protrusion or bite with the anterior teeth, and then there will be disclusion in the posterior. You can place a recording medium there and record the Christensen phenomena, kind of disocclusion, or the space, posterior interocclusal space can be recorded, and that can be used to program the articulator. Because in day-to-day practice, it may be difficult to do all that Gothic arch tracing and all those things. And we don't need all that eccentric movements other than protrusive for programming the Hanau articulator. So we can do it very simple by following this technique. Okay, so the next step is the selection of teeth. Now here there are two forms of teeth that are present. In the next slide you will be seeing that. Now whether to consider the anatomic form, whether to consider semi-anatomic form, or to consider a non-anatomic form is the one that has to be kept in mind. For establishing the balanced articulation, the selection of the posterior teeth is more important other than the anterior teeth, because anterior teeth basically work for aesthetics, whereas posterior teeth work for function. Okay, so we need to make a decision what shall be the cuspal height. All right, so we also have to think about the shade, shape and size and all those normal protocols that we are going to follow for the for selection of the teeth. And we also have to think what is going to be the cuspal angulation. So we can measure the cuspal angulation in this way from the midpoint. If we draw a tangent to the cusp, then the angulation there is what we can call as the cuspal inclinations. Now there are two types of teeth that are available generally. There is one is called as anatomic, another one is called as geometric. So geometric cusps are generally having a 20-degree angulation. They are good for balancing, whereas the anatomic cusps are good if the ridges are very well formed and if the interridge space is less, or so it's okay. We can use the anatomic when there is no or we are assured of having a very good retention and stability. So that is where the anatomic forms are used. Otherwise, geometric forms are good to establish the balance because they have 20-degree teeth and good anatomy, and there is no difference in the masticatory efficiency by using either of them. Okay, so we have to ask the dealers to provide us geometric teeth whenever we want to get the balance articulation done. Okay, so this is an article that is saying that the balanced occlusion is a favored occlusal design in arranging the artificial teeth in conventional complete dentures. It also preserves the dentulous ridge and influences the stability of the dentures. So that is what this article, which was published in the year of 2012, has come out with from this university. Okay, then we have to do the arrangement of teeth. Now, while arranging the anterior teeth, all these things we have to keep in mind: the aesthetics, overjet, overbite, arch form, smile line, etc. If we have to do the anterior recording, we have to do only the anterior teeth arrangement and then go for the recording of protrusive. Otherwise, we might do the whole of the arrangement and then do the trying. If we are not doing the, if we are using the Gothic arch tracers, and if you are recording the eccentric relation, then you can arrange all the teeth at a time. It doesn't matter. Okay, so the first thing that we have to keep in mind is the incisal guidance, because this is what is going to influence on the condylar, not on the condylar inclination though, but it influences the cuspal inclinations as well. So for the natural dentition, it does not matter much how much is the incisal guidance angle is, because the teeth are fixed down there. But for the dentures, it is very important to have the incisal guidance a little shallower, because the quicker they come into the incisal edge position, there will be a better stability. If there is a deeper overbite, then there is a possibility of destabilization of the denture. So we need to be careful about all these things. So generally, we don't keep the incisal guidance more than 10 degrees, and also the guideline is not to have the incisal guidance more than the condylar guidance. It always has to be less. Generally, for the balancing, we keep it between 5 degrees to 10 degrees. That is optimum condylar guidance, incisal guidance angle, sorry. Okay, so when we are arranging the anteriors, be careful with it. If it is class 1 arrangement or class 2 arrangement, still we keep it little shallower. And then if we are using the anterior trial and then recording the protrusive, when we put it back on the articulator, we can see that the pin is going to raise, because there is some amount of change in the vertical, because there is a incisal anterior teeth one to another coming in contact. So when the pin raises, that is the we have to tilt the incisal guidance angle to bring the pin in contact with the table. That is how the incisal guidance angle can be set for this particular gentleman. Okay, so that is how the incisal guidance angle can be adjusted after the anterior try-in. Okay, so when we go to arrange the posteriors, we will see a little more about this as we go on further. Now, we have to do a sequential arrangement, or we have to optimize the cuspal angles, and then we might need to do selective grinding, or all three of them may need to be done, and we also have to establish the compensatory curves. Okay, now before going into the arrangement of posterior teeth, I just want you to take a small quiz. All right, let us see how you score with it. Okay, so the question is, it becomes more difficult to obtain bilateral balance in a complete denture try-in setup when there is a shallow horizontal condylar guidance, there is a steep horizontal condylar guidance inclination, or there is a steep plane of occlusion, or there is a prominent compensating curve, or there is a steep cuspal inclination in the posterior teeth. What do you think? Well, scratch your heads. Well, let me give you the answer. It is the steep horizontal condylar inclination. Why? Because yes, as the condylar guidance increases, the disocclusion also is going to become more. So we have to increase the cuspal height, or we also have to accentuate the compensating curves. So either way, it is going to be a little difficult if the horizontal condylar guidance angle is more. So that is the difficulty. Okay, so let's go to the posterior teeth arrangement. Now here we have to keep in mind the compensating curves and the cuspal angulation. So the steeper the condylar guidance, as I told you, the compensatory curve will become more steeper, and also the cuspal angulations need to be steeper. So the lesser the condylar guidance angle, it will be easier to do the balancing. So generally, as we have experienced in my personal experience, with the younger age group of edentulous patients will have slightly higher condylar guidance up to 30 degrees. But if it is elderly individual crossing 60 years or so, the condylar guidance would not go beyond 20 to 25 degrees. That is my personal experience. Although there is no, I don't know if there is any research done on it. Well, the compensating curves are to be included in anteroposterior as well as mediolateral to maintain the cuspal contacts. So here we can oops, sorry, there is a small break. Well, when we do the lateral movements, we need to check that the contacts on the of the cusps. So on the working side, we need to have contact of the buccal cusp to buccal cusp of the maxillary, and the lingual cusp to lingual cusp of the mandibular. At the same time, on the opposite side or the balancing side, we need to have the functional cusp gliding over the functional cusp so that to maintain the contacts on both the sides simultaneously. That is important to observe when we are arranging the teeth. Okay. So we'll have a small question before we go further. Now, you all are aware about the Hanau squint. So how can you achieve bilateral balanced occlusion when the patient has a steep condylar guidance? Now, is it by increasing the occlusal plane, cusp height, and or compensating curves, or we can increase the cusp height, incisal guidance, and or a curve of Wilson, or by increasing the fossa depth, curve speed, or plane of orientation, or can we do it by decreasing the occlusal plane, incisal guidance, or cusp height? So which is your option if there is, if you want to achieve a bilateral balanced occlusion when the patient has steep condylar guidance? Well, you can scratch your head and find out, but I'll give you the answer now. It is by increasing the occlusal plane and then the cusp height and or compensating curves. So one of these things have to be done, or all of these have to be done. Well, when we are doing the arrangement of posteriority, there are three ways we can establish the balanced articulation. First thing is an alternate teeth arrangement technique, where we start with arranging the first mandibular first premolar, and then we go to arrange the maxillary first premolar, and then we arrange the mandibular second premolar and crisscrossing like that. Then the mandibular first molar, then the check for the inclination, check for the contacts, check whether there is in protrusive, in right lateral, left lateral. So whether the working side contacts and the balancing side contacts are good. And then we arrange the maxillary molar in accordance with the mandibular molar. And again, check for any inclination corrections. Here, when we are doing these inclination corrections, they always have to be done, both the maxillary and mandibular together. If we just correct any one and again close, the opposing tooth will just reposition itself back to the original. It does not change. So when we are changing here, we have to change them together. So likewise, as an crisscross manner in the alternate teeth, we can establish a very good balance, and it will be easy to establish the balance. That is my experience. So I generally follow this technique. But when we started learning about it, we were also taught about this technique where we arrange all the maxillary posteriors, then arrange the mandibular first molar in balance, and then check for all the balancing, then seal this tooth. That is going to guide you to establish the balance of the other teeth. Then after first molar, second premolar, and then the first premolar, and then the second molar, like that, in that order also the arrangement can be done. There is another third way of doing it, is you acrylize the maxillary denture, then arrange the mandibular teeth in balance with the maxillary denture. Of course, this takes a lot of time. You have to acrylize the maxillary and then acrylize the mandibular and so on and so forth. Practically, this technique is little difficult, but it has also been said by some of the experts where it need not to be an acrylized denture. At the time of arrangement of maxillary mandibular, we can do a selective grinding and establish the balance also. I generally don't prefer to grind much because we may lose the anatomy of the teeth. However, it's up to you. You can use any of the techniques. All the techniques work. It's not that one technique is superior to other and does not work, things like that. All the things are going to work. Okay, so just keep the functional contacts and the balancing side contacts, that is the working side contacts and the balancing side contacts. Verify them carefully before you go to the next step. Okay, so as we do the acrylization, there are polymerization errors or polymerization property of the material is going to inculcate some amount of errors into the denture. So we need to do the step as laboratory remount. Here again, we have to be verifying everything what we have done. So there can be errors that can happen during the polymerization because of the property, as I said, or while retrieving the dentures from the cast, and we have to check, put the dentures back on the articulator, and then check for all the contacts. The first we are going to check the vertical, correct the vertical, and then we are going to check the centric and then the eccentric contacts on the working and the balancing side. Okay, so we have to always write down the angulations on the base of the mounting so that we don't forget them. If you are handling many cases, you tend to forget what was the angulation there for this particular patient. So it's better to write down there so that we don't lose it. Then you just have to program the articulator to work on, and then you're fine to go through. Well, the next step is the clinical remount. There is a point that is called as real F. All of you are aware of it. It is the resiliency of the tissues. Now, all this time we are working on the cast which are rigid, and when we put it back into the patient where it is in the resilient tissues, there is a possibility of any changes in the minor positioning of the denture because of the resiliency, and then we have to record the centric once again, put it back on the articulator, and recheck for the contacts. So we have to re-establish the contacts for the working side and the balancing side in protrusive, all the three things for the balance. Okay, so this is another very important step along with the laboratory remount. We might have done the best of the arrangement, but after doing all that, if during the laboratory, if it gets changed, then it all goes in vain. So we need to instruct the laboratory, or as a postgraduate, when you are doing, you have to do a laboratory remount to re-establish, and then do the clinical remount to re-establish the contacts. That is very, very important. And to record the centric, there are different materials that can be used, but the centric has to be recorded at the first contact of the teeth. So you need to train the patient here to close and stop at the first contact of the teeth. Don't just ask the patient to bite and try to record, because the dentures will move and the condyles can accommodate this movement. That can possibly not give you any other contacts other than what you just saw in the patient's mouth. So it's always need to be train the patient to close and stop at the first contact. The moment the teeth come in contact, patient has to stop closing, so that position has to be recorded. So that will be the arc of movement that we are recording, and we have to establish the balance at that point. Okay, so that is very important when you are doing the clinical remount. So when we are doing the occlusal corrections for the clinical remount, we generally remove the vertical pin from the articulator, because here we are have to correct the centric relation first. So at that time we can remove the vertical pin, because the vertical has already been re-established by doing the laboratory remount. Here we just need to check for the good contacts because of the resiliency of the tissue. So there is no fear of losing the vertical. So the vertical pin can be removed, and then you can start doing the selective grinding. Well, you can follow the formulas of selective grinding as Bull's principle, or there are a couple of things that you can follow to establish the occlusal contacts, re-establish the occlusal contacts in selective grinding. Well, last but not the least is to verify using a T-scan. The T-scan can be a very good equipment to add up for the occlusal stability of the dentures, because this can tell where are the heavy contacts and where are the low intensity contacts. Because when we place the articulating paper, it just tells where are all the contacts, and it doesn't tell which contact came first, which contact came later, and where is the heavy contact and where is the light contact, things like that. So this may be come very handy to help the patient to establish good, stable, balanced articulation. Okay, so that is very important on this part. So here are one or two examples of balanced dentures. You can see the protrusive, all the teeth are coming in contact nicely, and here it is intercuspated and the teeth are having a good occlusion. This is on the working side contacts, and on the non-working side contacts also it is, although I have not put the picture here. Now this is another patient where we see a good happy smile, and inside the patient's mouth we can see the functional cusp or the working side contacts, and we can see the non-working side contacts here, and the same thing on the opposite side also. Okay, so this is how we have to work. That's the workflow, or step by step, to establish the balanced articulation and every step that we follow to make the dentures is very, very important. Don't compromise at any step, because every step will contribute to make the dentures with favorable prognosis. That is what is important. And all these things can reduce the patient's adaptability to the dentures. The time to adapt to the dentures will be shortened, and the patients will really be happy about it. Okay, just before going, I'm going to give you a small questionnaire, 1 or 2 questions only. Don't worry, I'm not going to take it long. All right, so this is just another question. The dentist has requested the maxillary mandibular wax trial dentures, and you notice that the posterior teeth are not in contact. Okay, so what do you think that need to be done? We can raise the plane of occlusion in the posterior region or lower the plane of occlusion in the posterior region because there is no contact, or reduce the prominence of the compensating curve, or close the vertical dimension of occlusion on the articulator. What do you think you want to do? Well, we can just simply raise the plane of occlusion. Raising the plane of occlusion in the sense it is also the correct the compensating curve. So with that we can get the balance. Okay. So just another question. This is the last question for this. So what do you think about this? All the following are true regarding the patient's perception of complete denture, occlusal schemes, and the clinician's objective evaluation of treatment except one. Which one is the exception? So anatomic teeth arranged for conventional and lingualized balanced occlusion. The aesthetic factors do not affect the patient perceptions. Lingualized balance was favored when the edentulous ridge was severely atrophied, or little high quality evidence is available to guide complete dentures occlusion. Well, it is the answer B. Aesthetic factors do not affect patient perceptions. So when we are trying to think about comparing the two different types of occlusion, aesthetic factors are not really kept in mind. Well, just to go back on this, we started with this objective to do the balanced articulation. Keep 3 things in mind: that we have to achieve the simultaneous contact and no interference, a smooth glide on one over the other. At the same time, the incisal guidance pin should always remain in contact with the incisal guidance table. If it is out of contact, means that is an interference. It is not, even though you might see contact on the working side and the balancing side contacts, but it will be an interference because it is not along the incisal guidance. So be watchful on the incisal guidance pin and the insert contact with the incisal guidance table. Okay, just to recapitulate the diagnosis, keep these points in mind, and then when you are making the impressions, make good impressions. That is very important. And then the jaw relation recording, so establishing the plane, establishing the centric relation, recording the eccentric relations, and also the orientation relation. Now, the jaw relation recording along with the programming of the articulator is equally important. Now here we are going to have these factors that is to be kept in mind by recording the eccentric relations. Horizontal condylar guidance to be adjusted, then the incisal guidance has to be adjusted, the lateral condylar guidance has to be adjusted. Keep all these things in mind as you select the teeth and then the arrangement of teeth, whether you want to go for anatomic, semi-anatomic. As I said, there are anatomic form and the geographic forms. I generally prefer to go for the geographic forms whenever we want to establish the balance. Otherwise, we can use the anatomic forms also, but it might need some amount of selective grinding when we are using the anatomic forms. So the arrangement of teeth is important. So you can establish the balance by correcting the inclinations and selective grinding and so on and so forth. Now, it is also important to know that if we are using non-anatomic teeth, we can use the balancing ramps or we can use the pleasure curve to maintain the balance and stability for the occlusal rims. The dentures. Okay, so another important thing that we have to keep in mind is the lab remounting and then followed by clinical remounting before we actually insert and send the patient, insert the dentures and send the patient off with all the instructions to be given. Of course, equilibrating using the T-scan can be best to optimize the occlusal contacts, but if you don't have, it is not to be worried. But the clinical remounting has to be done. That is very, very important and most important along with the lab remounting. All right, so that is all about establishing the balanced dentures or balanced articulation in complete denture patients. And I hope I have given you a good information step by step what things have to be kept in mind and how to make it. It is very easy. Don't think that arranging the teeth and balance is very difficult. It's very time taking. No, it's not. Maybe it's true when you are just starting. After doing a couple of cases, you just find it very easy. And even if you are not doing any kind of these protrusive and the recordings, your arrangement would automatically be in balance because your skill is inculcated within you. So you don't make mistakes out of it. And it becomes very easy. Well, wish you all the best and thank you. I thank the organizers here, including myself, and as well as the Indian Prosthodontic Society for giving me this opportunity. So thank you. Wish you all the best. Bye. Take care.
Thank you very much, sir. With your kind permission, there are a few questions that are slowly popping in. There is one question. It says, what's your opinion on using CBCT or a lateral ceph to determine the condylar guidance angle, sir?
Well, yes, it is possible to use a panoramic radiograph to establish the condylar guidance. There are studies that have been told, that have been done, including we conducted one in our college also, to compare recording the protrusive directly in the patient and comparing it from the panoramic radiograph. It does match to a very, very close. So we can take, but a good quality radiograph is important. That is the first thing. Then CBCT to say, grossly it might look good, but CBCT always depends upon the sections. So where you are making the section, that makes the difference. So there is a possibility of we might end up with some errors because it's slicing at different levels. So there is a possibility, but it can also be used. At the same time, nowadays we do have a digital gadgets where they can record, like cadet system, where we can record the protrusive and right lateral, left lateral. They can directly on the screen, we can see the angulations and then program the articulator. That is also possible.
Sir, with your permission, one more. Can we do balanced articulation in digital dentures is the next question.
Well, yes, they do claim that it can be established, but personally, I don't have an experience with it. But they still have the issues because the virtual articulator, if we can, there are gadgets coming for the virtual Facebook transfer. So once that becomes more popular, the virtual phase co-transfer gets incorporated into the virtual articulator. Possibly, we can certainly get each tooth need to be adjusted in orientation to get the balance. Or maybe in time, artificial intelligence can take over. It can arrange the things in balance just like that with the click of mouse.
Sir, again, with your permission, sir, how to measure interarch space?
Well, it is not very difficult. You just need to have, there are two ways you have to train your eyes. Most simple is you just have the patient in rest position, retract the lips, and keep little finger on the chin so that to feel or prevent the patient from opening the mouth. Because the moment we take our fingers close to the mouth, the patient opens. So we just have to keep our little finger to the supporting the chin and then retract the fingers, retract the lips, and watch carefully. So how much is the space? That is the interocclusal space at rest position. So for occlusion, you have to reduce 2-3 millimeters from there.
Sir, thank you. And one last one, I guess. Sir, what is the importance of zeroing of the articulator is the next question, sir.
Well, the manufacturers do say that it is required, but the zeroing of articulator is always mentioned only in HANA articulator. In remaining articulators, they don't really talk about it. Personally, I don't feel it has much of a meaning because the condylar head is going to remain there only, whatever the angulations we rotate. Since whether we keep it 30 degrees or whether we keep it at 0 degrees, it wouldn't make difference. But what I presume with experience is, if we zero the articulator as the manufacturer says, that keeping it at 30 degrees, the condylar guidance, and keeping it 25 degrees or more with the lateral condylar guidance, when we keep it, the lateral condylar guidance, it locks the maxillary member from any lateral movements. And the condylar guidance, keeping it 30, could be a starting point for it to rotate. From 30 degrees, it may be a very small rotation that it has to do when we are programming. Otherwise, from 0, it has to move. It may be a little more to move, and there is a possibility of, that we may not get the exact condylar guidance. That could be the reason. That's what I feel. That's what I experienced.
With your permission, one last one, I guess. Sir, how can we check the interference during tracing, sir?
Interference during?
Tracing, Gothic arch tracing, sir.
Gothic arch tracing. Gothic arch tracing doesn't have any interferences. No, it's a flat bed. On that, it is a single point that will be moving. But we have to see that we have to retract the cheek and see for any contacts of the occlusal rims. Sometimes if the patient bites harder, it might collapse or it might get sunk into the wax rims, and there is a possibility that the occlusal rims may come very close or in contact. Then there is a possibility of incorrect recording of the tracing. That's just we have to keep in mind.
So the last one is the significance of why we limit our protrusion, sir. Like why the 6 millimeters is the last question, sir.
Well, it's not really required to do more. It's also because we try to keep it within the functional limits. And for the translation of the condyle out of the glenoid first, it just needs 6 millimeters. More than that doesn't really make a significance, and it will also put the patient in confusion as because we cannot hold it in a altered position for long. There will be a muscle fatigue, and the patient slowly, he might move backwards and the recording may go wrong. That's why we just keep it 6 millimeters. So it is simple to record, and that is the maximum we require for translation to record.
Thank you so much, sir. We will probably stop there. I would like to thank you on behalf of everyone. The audience was a superb lecture.
Prakash, can I ask sir some questions so that
Please,
the silent spectators or people who wanted to ask certain pertinent questions, I think these questions will add value because I want to hear the answers from the teacher of teachers. Okay. Sir, is it fine, sir, with your permission?
Yeah, perfectly.
Sir, as you are told 6 millimeters, that was in my mind why earlier our teachers used to tell 8 millimeters. If you remember Dr. Joshi sir, SM Joshi sir,
Yeah.
who is your teacher as well as my teacher, used to insist that 8 millimeters. You had answered that, sir. Then there is one important thing when we were the students, we used to use H2, Anu articulator H2. In that it was L is equal to H by 12 was embossed below that. Now the present articulators, the wide view, it is not there. So do you think it is not that important now?
It is still same. It still works the same, but only thing now they are not printing it because in sometimes they say that we can do lateral recordings also and transfer to the articulator. So maybe it works good if we are trying to do a full mouth rehab, and because this is a semi-adjustable articulator for a complete denture, we would not require so much of lateral recordings and transferring it to the articulator. The formula would still work sufficiently. That's what I feel.
Then one more small doubt is when our teachers, especially from our teachers in the Karnataka region, they used to tell centric has to be perforated and the protrusive guide has to be near perforation. But whereas I heard from other teachers from other places that centric should be perforated and protrusive, if it is not perforated also it is fine. What do you believe? Which is correct?
Well, I believe that both have to be perforated. Because that is the only point of contact between maxillary and mandibular. If there is no contact between maxillary and mandibular, then there is always a possibility of movement of the mandibular denture base. So the stability of the mandibular depending upon that contact. If it is not in contact, there is a possibility of unstable mandibular and the recording is incorrect.
Sir, if I may, just for the point of discussion, sir, isn't it probably that a certain degree of Christensen's phenomenon is taking place? We have these extremely stable denture bases, but during protrusion, there's this very minuscule opening towards the back, which we will subsequently compensate with the compensatory curves during the teeth setting. So probably that is why they have said that it's probably okay not to have the perforation. Just that second line of thought might be based upon that, sir. Yeah, that is possible, but what I look at it as if there is a disocclusion, it is moving forward. Yes, sir. The mandibular is moving forward, so it will still be in contact with the plate. Okay. That is how I look at it. Now, if we try to see the Gothic arch tracing as the pin is moving, we still want to have the contact. If we see the intraoral tracers, they will still grave out the arrowhead point, because in protrusive also it remains in contact, in centric also it remains in contact. So that is just a replacement of ball with the pin there to maintain the contact. So the same phenomena will be applied here also. And that is why I believe that even in protrusive recording, it should be in contact. Otherwise, there is always a chance for the movement of the bases, especially the mandibular base. That's how I look at it as. Thank you very much, sir.
Dr. Dal wants to come and talk something. He wants to give an input. Dr. Rupinder.
With your permission, can I just give an input, sir?
Yeah, sure. Please go ahead.
One of the research what we did was we took a radiograph, transcranial and transpharyngeal. Sir, you remember in my exam we had done that. There is a technique called as open and close mouth technique of TMG radiograph, where what we can do is we can record the same position of the condyle by asking the patient to open and close. When that condyle transverses, we can draw a horizontal plane and condylar guidance can be replicated by drawing that angle by the same reference point. And we found as a suggested student in the exam that it was only 1 or 2 degree difference with what we found, sir. So transcranial and transpharyngeal TMG radiograph can be used as an agent rather than CBCT and OPG. And second, sir, one more thing, somebody asked the protrusive interference. Actually, what happens, sir, when we protrude the heels of the denture base, they are the biggest problem because the maxillary, the occlusal rim, the student extend too much posteriorly. The heels touches and causes negative downward movement. So when you're doing tracing, do not extend the maxillary rim too much posteriorly to prevent this frontal interference. And that is why one of the reasons 6 millimeter came was if you transverse too much, the posterior of the mandibular denture base will interfere and cause a more steeper incline. Plus, to record minimum articular eminence slope, 4 or 6 mm is enough to draw a tangent to record the condylar guidance. And the last point was, if you protrude, the gap center bearing point should be in contact or not. It has to be in contact because that is the name of it, central bearing point. If it doesn't contact, your forces are tipped forward and the Christensen phenomenon will be more recorded, as Sir said. So the contact in both the records, centric and protrusive, is mandatory to record. See that the tipping will be occurring, but the center bearing point will be touching there only. If it opens, there are chances of excess Christensen phenomenon being recorded, sir. This is my input, sir. That's why I asked them to unmute. Sorry, sir. In between, I just spoke.
No, it's a good inputs. Yeah.
Thank you, sir.
Thank you, sir. Thank you, one and all. It was an awesome session. And I personally loved how sir kept giving us those mind-boggling quiz questions. So those were like really eye-openers to the fact that we all have to understand that there is this wonderful interplay between those 3 factors on one side. If you forget about the incisal guidance and the condylar guidance, these 3 factors can influence one another tremendously so. So thanks once again, sir, for that lovely session. And just to add a few points for the students' point of view, number one, as we have seen sir insisting upon every step being significant, very important is for you to analyze your occlusal contacts. You may want to use Bosch 200 microns BK01 paper with your Miller's forceps on either side, or the BK03 horseshoe paper. That will really give you simultaneous contacts, the understanding of it, number one. Number two, there are a lot of people who would think that digital dentures would rule out all this. No, as of now, you still have to make proper impressions. You can only scan the cast. And similarly, even if you do a digital processing of the setting, which has been done virtually, you still have to do the equilibration manually. So all of you get ready for a lovely session of learning how to put the teeth in with a live demonstration coming up next. I once again thank the organizers and Dr. Sajjan sir for the superb presentation. Thank you, sir.
Thank you, Dr. Prakash and Dr. Ravi.
Thank you, sir. The entire the Vishnu Dental College team, especially the team prosthetic department, Dr. Sajjan sir, Dr. Ramaraj Garu, Dr. Bhimavaram Rao, Dr. MS Raj Garu, and other faculty members. And I also thank the IPS AP State Branch, the President, Dr. Narendra Garu, and our dear Shesha Reddy for giving me this honor to listen to your lecture and let me ask some questions on behalf of the students. Thank you very much, sir. It is a pleasure to be with you.
Thank you all so much. Thank you, Rupinder, and all the postgraduates back there.
Sir, now certificate of appreciation will be presented to Dr. Suresh Sajjan, sir. Kindly accept the certificate, sir.
Thank you. I accept.
Certificate of appreciation will be presented to Dr. Ravi Shankar, sir. Kindly accept the certificate, sir.
Thank you very much.
Certificate of appreciation will be presented to Dr. R. Prakash, sir. Sir, kindly accept the certificate, sir.
Thank you so very much. Thank you.
Next session will be a live demo of anterior teeth arrangement by Dr. Suresh Sajjan, sir, which will commence within few minutes.
Hi, I'm Dr. Suresh Sajjan, the head of the department in prosthodontics, also principal of Vishnu Dental College. I welcome all of you to this continuing dental education that we have planned for the arrangement of teeth and balanced articulation, because we feel that arrangement of teeth is one of the area which is less addressed because a lot of labs are taking over, but it is for us to know every part of the arrangement of teeth. Then when it comes back from the laboratory, we should be able to do what is the necessary modifications to individualize for the patients. So on behalf of management and Vishnu Dental College, I welcome you all. In this program, we are going to take you through for the arrangement of teeth. Step by step, I'm going to take you from the anterior and the posteriors individually. Then you can witness how the arrangement could be done in a simplified manner. And it's good to see all of you here, and let us make it a productive one. All right. Well, we are going to see how to arrange the anterior teeth today in this part of the demonstration. Now, first step we need to do is we need to have the midline marked. So we have the midline marked from the patient already. That has to be extended onto the cast. We need this because sometimes we might have to change the arrangement, and that time we might miss out with the midline where it was for the patient. So we have to mark that first. Then as we start the arrangement, we also have to mark the canine lines here. So I'm just keeping the scale horizontally to the incisor papilla, the distal of the incisor papilla, to mark here for the position of the canines. So I just mark it here and here and here. So that will help us when we start doing the arrangement where the canines are supposed to come. Okay. Now, just before starting the arrangement, you might have already selected the teeth as appropriate for the patient. Then these are stock teeth, so they'll have a different height, which may or may not coincide with what we require. So we just have to check whether it is good for us to continue the arrangement, or do we need any corrections to be done in the form of grinding, reducing the height, so on and so forth. So we just need to eliminate all this wax here so that it will not cause any issues. Then place it here and check whether there is sufficient height for arranging the teeth, or do we need to do some grinding. In this case, it appears okay, although it might require a small corrections to be done, because we can see here the base is up to this point and the occlusal, the teeth are slightly more extending. So I may need to grind a little part of it. I'll also show how to grind and what point we have to keep in mind before grinding. Okay. Yeah, we placed one tooth. Let us place the other two teeth also and see how it looks. And we can also verify the size, whether we have selected them appropriately as we place them here. And then we can check it's coinciding with the canine marking what we have done, the distal surface of the canine. So we can see here it's perfectly matching. All right, so what we are going to do now is we are going to grind these teeth a little bit because they are looking a little longer. We might have difficulty in placing them. So we are just going to grind these teeth a little bit. Okay. Let us make the grinding. What we have to keep in mind before grinding is we are not going to just flatten the surface. We have to maintain the concavity here so that it is going to be approximated to the convex surface of the temporary base or the record base. Okay, that is very important. Don't just flatten this, then it will not fit. We need to maintain this concave surface. So we are going to grind this surface. This is it's called as a ridge slab surface because it's going to overlap the ridge. We are not going to reduce much of the height in the labial surface. We are grinding only the ridge slab surface to accommodate the teeth. Okay. Yeah, and this should be sufficient. You can appreciate here we have still maintained this concave surface on the ridge slab. Alright, as we start doing the arrangement, we have the midline marked here, so we are going to follow the midline and just place the tooth once again here. After grinding, you are ready. Just mark about a millimeter wider than the tooth, so it helps us to how much wax to be softened or how much wax to be removed. So using wax spatula, I generally prefer to use a wax spatula to remove the wax, and I'm just going to soften the wax here. Reduce some wax there so that it will be active to accommodate the tooth. Now the tooth has incisally it is shallow and cervically it is thicker, so I'm removing a little deeper in the cervical side and little shallow in the incisal area. So I'm just softening this wax here. See that it is not molten wax. If it melts like this, you just wait for a little while so that it will be semi-solid. Because if it is molten, it is going to shrink more, and as it shrinks more, we will have more movement of the tooth than where it is placed. Just wait for a little while, or you can blow it a little and then place the tooth inside. We need to be careful to follow the occlusion ring. It has to be placed within the occlusion ring. Now I'm still finding it a little difficult to put it in because maybe there is an interference there. So it's coming about a millimeter above the occlusion ring. So I just need to grind a little bit more and then I can go ahead and place. Okay, sometimes the record base may be thicker, so we can reduce the record base if we are not able to place the tooth immediately. So just to create the space, we may need to reduce it, but be careful. If it becomes too thin, it might perforate. So here I think this should be good enough for me to do. Here we can see now the teeth I have softened the wax, and I have also melted the wax a little bit and kept it ready. It is not molten, it is semi-solid state. So now I'm going to place the tooth in position following the regular principles what we normally do. And then what also I'm doing is I'm just trying to feel the tooth here so that it is at the level, and it has to be within the occlusal rim, as you can see here. And all this excess wax that come out, I'm not going to remove it. rather I just shape it so that it can be part of the carving. So I don't have to add up wax once again for doing the carving. Just shape it and leave it there, allow it to cool down, then you can use it for waxing and carving. It just saves a lot of time for you later. Okay, so that's how we can simply, quickly, we can arrange the central incisor. I have now placed the central lateral and the canine. You can see that we are within the occlusal rim, so we have not changed the lip support by placing them labial to the occlusal rim. And now all this in the back, we can remove this. We don't really need this to be here. Just remove this wax. You can either remove it immediately after each tooth, or you can collectively remove it after arranging the canine. So it's up to you. There's no hard and fast rule that you need to remove it at what point of time. So okay, so now what you can also observe is I have not removed this wax to add wax again. I have just kept that extra wax that has come out on the labial surface, and I can just shape it, and then my carving is almost done. My waxing is almost done. A little bit I need to do when I'm doing the finishing work in the end. So it saves a lot of time, and it makes your life easy. So we can just remove this excess wax here to make it more aesthetic. And your carving is more or less done. Okay, so this is easier way to do the anterior arrangement, especially the maxillary anteriors. Now, don't leave any wax interdentally where it can come up to the incisal edges. It is always preferable to know where the contact point will be and remove the wax up to the contact point. That's very important. Don't let the wax flow in there, and it looks very bad when we complete the denture like that. Okay, so you're just going to smoothen this here on the lingual side. Just you can smoothen and run the wax, and that can be done. Okay, so that is how we can arrange the maxillary anterior. So all the three teeth are in, and the carving is also almost done. Just a little bit finishing is required in the end. When I complete, I can do it at that point of time. Okay, so same way I'm going to arrange the other side also. I'll continue this, and then we can come back to the lower anteriors. Now we can just, before finishing, we can just see where is the canine marking that we have done. It is approximating to the canine perfectly. So that means the size of the teeth what we have selected is appropriate. Now in the patient, when we mark the canine lines on the occlusal rim, we can use a flexible scale from here to here, or if you don't have flexible scale, you can just take a thread and place it from this point or the canine line where it is marked, and mark till here, and then that you can measure what is the length. Okay, and then this is about 45 millimeters. So then we can say that these teeth are having the same dimension here. Okay, so you can see that the the half of it is perfect to the teeth. All right, let's place it correctly. So you can see that it is to the half of it. So it's nicely, can you see it? Yeah. Okay, so that is how the anterior teeth has to be, the size, the mesodistal width of the teeth has to be selected. And then as we arrange, I'm going to arrange this part of it also, then we can come back to you. All right, so there are many ways we can speed up our arrangement. Now here what I'm going to do is I'm going to remove this wax, which I would be removing later. Now I'm removing this earlier. We can either section this wax and then start arranging, or sometimes we can remove this whole segment of wax, then just make a roll of wax, place it there, and then we can place all the three teeth simultaneously also. Okay, so this is to make our work faster and easier, we can do it this way also. Okay, now you can watch. Now I'm going to place all the three teeth here at the same time, and it becomes easy. So I'm going to soften all this wax. Always be careful when we are softening the wax. The adjacent tooth should not be disturbed. Otherwise, you have to spend time in correcting that and correcting this and correcting this and correcting that. So you will be spending a lot of time and your arrangement will never be good. So I'm just softening this wax so that I'll have a good foundation, and then I can place the teeth there. So it becomes easy. Place one central, just keep that wax there, don't push it away. Maybe I need to do a little more grinding here. Let me see. Then we can place the lateral. And then we can place the canine. So the three teeth like this, we can place it simultaneously, and then we can correct the arch form. So we can make it very fast. Okay. Yep. Arranged all the 6 teeth now. They're positioned well, and we have also checked the arch form, whether it is confining to the sulcus and the shape of the arch, as well as the canine position. As we have marked that the canine positions are reasonably good. Okay, so that gives us a good indication. Now, since a lot of this wax I did not remove, so I just redistributed it. So you can see the difference when I have redistributed it here, the wax, and here I removed part of this bunch of wax, and then I need to add a little wax there to get the shape done. Okay, so as we do the anteriors, remove all the wax from the palatal side, and then we can go on to arrange the mandibular anteriors. Now once we have arranged the anteriors, the maxillary anteriors, then we need to put it back on the articulator, and we can raise the pin because the posterior part of the occlusal ribs can maintain the vertical at this point, and then we check how much is the overjet. All right, so generally it will be about 1 to 2 millimeters maximum If it is more than that, then it is, we consider it as class 2 situation or retrographic mandible. Then before arranging the mandibular anteriors, we need to adjust the incisal guidance table, because at least arbitrarily we have to adjust so that later on we can check it in the patient for the overjet overbite and finalize it at the patient. Now, to start with, we are going to change the angulation here to 10 degrees. So generally it will be, just loosen this lower one, loosen the lower screw, thumb screw, and this can be rotated. So there's 0, 10 and 20. So we are going to keep it to 10 degrees and then tighten it. It's difficult for you all to see, so trust me. The same way here to the lateral guidance also, we are going to keep it to about 5 degrees or maximum 10 degrees. We never have to later on, it also depends upon the condylar guidance. The incisal guidance will not be more than the condylar guidance. So generally we keep it to between 5 and 10 degrees of incisal guidance so that it will be useful for the arrangement of teeth. Okay, so I have adjusted here for 10 degrees of the anteposterior and about 5 to 7 degrees here on both the lateral sides. Okay. Now we also have to keep the condylar guidance, say about 25 degrees, 20 to 25 degrees as an average, because we try to check it up, check the anterior teeth arrangement for a balance before actually put it in the patient. And we also have to adjust the lateral condylar guidance. So if we are keeping this about 25, then if we apply the formula h by 8 plus 12, it gives me around 15 degrees. So I have adjusted here to 15 degrees on both sides, and I have locked the centric locks. Okay. Yeah, as we start arranging the mandibular anteriors, again we have to have the midline marked and extend the midline to the mandibular occlusal rim. That is very important, so that it helps for us to arrange the teeth. Now, while we are arranging the mandibular anteriors, we can do it in two ways. We can either start from the central incisor and go ahead, or since we already have the maxillary canines in position, we can arrange the canine first and then come towards the central incisor. Once the canine is arranged, then central incisor, and then we go to the lateral incisor. Okay. So now we are going to start with the canine first. So I'm marking here where the canine is going to come. The tip of the canine is here. So my mandibular canine should terminate, the distal proximal surface of the mandibular canine should terminate here. So the same way on this side, I'm going to mark there the tip of the mandibular maxillary canine. So the mandibular canine should terminate here. Okay. So now from here I can start doing the arrangement. Yeah. All right, you can see now I have arranged the canine. What I have done here is I have given a small overbite to the overlap. What I also did was a small trick. What I did is I have loosened it here. I moved to the canine position, and then I lock at this point. And then when I place the mandibular canine, it will not have any interference, and the required amount of overlap can be achieved there. So you can see here, we have got the amount of overbite that has been there, and the overjet also gets automatically adjusted. At the same time, since we have marked here where is the tip of the canine, so the distal proximal surface of the mandibular canine is coinciding with it. Okay. Okay, so here you can see now I have arranged the central incisor, mandibular central incisor. So what I did again here is, in order to get balance for the 10 degrees, what I have put the incisal guidance here, I bring it down, loosen it enough first, and check for the movement, the free movement on both sides. Okay. Then I'm moving it to the protrusive position, and I lock it there and see that the teeth remain in contact. Okay. So we can see here the incisors are edge to edge when it is in protrusive, and when I unlock it, it comes back to the centric, and there we can see that there is the overjet and the overbite. Okay, so that is how we do it for the central incisor. Now we can go ahead and arrange the lateral incisor. If the lateral incisor, if the space is sufficient, we can directly arrange it, or if it is wider, probably we may need to grind it a little bit. Then we can take a choice either to grind both the central incisors or a little bit of canine to provide the space for the lateral incisor. Here I may need to grind a little bit of the canine, and then I can get enough space for the lateral incisor to arrange. Yeah. So here, taking the guidance from the lateral, the central incisor and the canine, I have arranged the lateral incisor, and then I just check whether what we have achieved to establish the anterior guidance and the anterior balance. So when I try to move this into protrusive, I have nice contacts between the central incisors and the lateral incisor and the canine as well, and there is no rise in the pin. That is important. So when we are taking it to protrusive, there should be contacts here, and the pin should be remaining in contact. So that means we have established the anterior guidance for the anterior teeth. Okay. So here again, I'm following the same pattern as I started with the canine. Then I've arranged the central incisor, and now I'm going to place the lateral incisor in that space, and then it just fits in there. Alright, so just check for the plane, and then we can put it on the articulator and check for the protrusive. Okay, so just loosening both the sides, and then check for the protrusive. As we go back here. Okay, I think that's fair enough. There is no a small adjustment that was required. So I'm keeping in protrusive and trying to adjust these central and lateral incisors, so it will be having the incisor to incisor contact. Okay, that's good.
With the knowledge we gain today, we will again gather tomorrow to dive into the ocean of occlusion. Thank you one and all for your patience and cooperation. See you all tomorrow. Take care. Live demo video will be played again. Interested candidates can hear that. Thank you one and all.
Hi, I'm Dr. Suresh Sachin, the head of the department in prosthodontics, also principal of Vishnu Dental College. I welcome all of you to this continuing dental education that we have planned for the arrangement of teeth and balanced articulation, because we feel that arrangement of teeth is one of the area which is less addressed, because a lot of labs are taking over, but it is for us to know every part of the arrangement of teeth. Then when it comes back from the laboratory, we should be able to do what is the necessary modifications to individualize for the patients. So on behalf of management and Vishnu Dental College, I welcome you all. In this program, we are going to take you through for the arrangement of teeth. Step by step, I'm going to take you from the anterior and the posteriors individually. Then you can witness how the arrangement could be done in a simplified manner. And it's good to see all of you here, and let us make it a productive one. All right. Well, we are going to see how to arrange the anterior teeth today in this part of the demonstration. Now, first step we need to do is we need to have the midline marked. So we have the midline marked from the patient already. That has to be extended onto the cast. We need this because sometimes we might have to change the arrangement, and that time we might miss out with the midline where it was for the patient. So we have to mark that first. Then as we start the arrangement, we also have to mark the canine lines here. So I'm just keeping the scale horizontally to the incisor papilla, the distal of the incisor papilla, to mark here for the position of the canines. So I just mark it here and here and here. So that will help us when we start doing the arrangement where the canines are supposed to come. Okay. Now, just before starting the arrangement, you might have already selected the teeth as appropriate for the patient. Then these are stock teeth, so they'll have a different height, which may or may not coincide with what we require. So we just have to check whether it is good for us to continue the arrangement, or do we need any corrections to be done in the form of grinding, reducing the height, so on and so forth. So we just need to eliminate all this wax here so that it will not cause any issues. Then place it here and check whether there is sufficient height for arranging the teeth, or do we need to do some grinding. In this case, it appears okay, although it might require small corrections to be done, because we can see here the base is up to this point and the occlusal, the teeth are slightly more extending. So I may need to grind a little part of it. I'll also show how to grind and what point we have to keep in mind before grinding. Okay. Yeah, we placed one tooth. Let us place the other two teeth also and see how it looks. And we can also verify the size, whether we have selected them appropriately as we place them here. And then we can check it's coinciding with the canine marking what we have done, the distal surface of the canine. So you can see here it's perfectly matching. All right, so what we are going to do now is we are going to grind these teeth a little bit because they are looking a little longer. We might have difficulty in placing them. So we are just going to grind these teeth a little bit. Okay. Let us make the grinding. What we have to keep in mind before grinding is we are not going to just flatten the surface. We have to maintain the concavity here so that it is going to be approximated to the convex surface of the temporary base or the record base. Okay, that is very important. Don't just flatten this, then it will not fit. We need to maintain this concave surface. So we are going to grind this surface. This is it's called as a ridge lap surface because it's going to overlap the ridge. We are not going to reduce much of the height in the labial surface. We are grinding only the ridge lap surface to accommodate the teeth. Okay. Yeah, I think this should be sufficient. You can appreciate here we have still maintained this concave surface on the ridge lap. Alright, as we start doing the arrangement, we have the midline marked here, so we are going to follow the midline and just place the tooth once again here. After grinding, you are ready, just mark about a millimeter wider than the tooth, so it helps us to how much wax to be softened or how much wax to be removed. So using wax spatula, I generally prefer to use a wax spatula to remove the wax, and I'm just going to soften the wax here. Reduce some wax there so that it will be acting to accommodate the tooth. Now the tooth has incisally it is shallow and cervically it is thicker, so I'm removing a little deeper in the cervical side and little shallow in the incisal area. So I'm just softening this wax here. See that it is not molten wax. If it melts like this, you just wait for a little while so that it will be semi-solid. Because if it is molten, it is going to shrink more, and as it shrinks more, we will have more movement of the tooth than where it is placed. Just wait for a little while, or you can blow it a little and then place the tooth inside. We need to be careful to follow the occlusal ring. It has to be placed within the occlusal ring. Now I'm still finding it a little difficult to put it in because maybe there is an interference there. So it's coming about a millimeter above the occlusal ring. So I just need to grind a little bit more and then I can go ahead and place. Okay, sometimes the the record base may be thicker, so we can reduce the record base if we are not able to place the tooth immediately. So just to create the space, we may need to reduce it, but be careful. If it becomes too thin, it might perforate. So here I think it should be good enough for me to do. Here we can see now the teeth are there. I have softened the wax, and I have also melted the wax a little bit and kept it ready. It is not molten, it is semi-solid state. So now I'm going to place the tooth in position following the regular principles what we normally do. And then what also I'm doing is I'm just trying to feel the tooth here so that it is at the level, and it has to be within the occlusal rim, as you can see here. And all this excess wax that come out, I'm not going to remove it, rather I just shape it so that it can be part of the carving. So I don't have to add up wax once again for doing the carving. Just shape it and leave it there, allow it to cool down, then you can use it for waxing and carving. It just saves a lot of time for you later. Okay, so that's how we can simply, quickly, we can arrange the central incisor. I have now placed the central lateral and the canine. You can see that we are within the occlusal rim, so we have not changed the lip support by placing them labial to the occlusal rim. And now all this in the back, we can remove this. We don't really need this to be here. Just remove this wax. You can either remove it immediately after each tooth, or you can collectively remove it after arranging the canine. So it's up to you. There's no hard and fast rule that you need to remove it at what point of time. So okay, so now what you can also observe is I have not removed this wax to add wax again. I have just kept that extra wax that has come out on the labial surface, and I can just shape it, and then my carving is almost done. My waxing is almost done. A little bit I need to do when I'm doing the finishing work in the end. So it saves a lot of time, and it makes your life easy. So we can just remove this excess wax here to make it more aesthetic. And here carving is more or less done. Okay, so this is easier way to do the anterior arrangement, especially the maxillary anteriors. Now, don't leave any wax interdentally where it can come up to the incisal edges. It is always preferable to know where the contact point will be and remove the wax up to the contact point. That's very important. Don't let the wax flow in there, and it looks very bad when we complete the denture like that. Okay, so you're just going to smoothen this here on the lingual side. Just you can smoothen and run the wax, and that can be done. Okay, so that is how we can arrange the maxillary anterior. So all the three teeth are in, and the carving is also almost done. Just a little bit finishing is required in the end. When I complete, I can do it at that point of time. Okay, so same way I'm going to arrange the other side also. I'll continue this, and then we can come back to the lower anteriors. Now we can just, before finishing, we can just see where is the canine marking that we have done. It is approximating to the canine perfectly. So that means the size of the teeth what we have selected is appropriate. Now in the patient, when we mark the canine lines on the occlusal rim, we can use a flexible scale from here to here, or if you don't have flexible scale, you can just take a thread and place it from this point or the canine line where it is marked, and mark till here, and then that you can measure what is the length. Okay, and then this is about 45 millimeters. So then we can say that these teeth are having the same dimension here. Okay, so you can see that the half of it is perfect to the teeth. All right, let's place it correctly. So you can see that it is to the half of it, so it's nicely, can you see it? Yeah. Okay, so that is how the anterior teeth has to be, the size, the mesodistal width of the teeth has to be selected. And then as we arrange, I'm going to arrange this part of it also, then we can come back to you. All right, so there are many ways we can speed up our arrangement. Now here what I'm going to do is I'm going to remove this wax, which I would be removing later. Now I'm removing this earlier. You can either section this wax and then start arranging, or sometimes we can remove this whole segment of wax, then just make a roll of wax, place it there, and then we can place all the three teeth simultaneously also. Okay, so this is to make our work faster and easier, we can do it this way also. Okay, now you can watch. Now I'm going to place all the three teeth here at the same time, and it becomes easy. So I'm going to soften all this wax. Always be careful when we are softening the wax. The adjacent tooth should not be disturbed. Otherwise, you have to spend time in correcting that and correcting this and correcting this and correcting that. So you will be spending a lot of time and your arrangement will never be good. So I'm just softening this wax so that I'll have a good foundation, and then I can place the teeth there. So it becomes easy. Place one central, just keep that wax there, don't push it away. Maybe I need to do a little more grinding here. Let me see. Then we can place the lateral. And then we can place the canine. So the three teeth like this, we can place it simultaneously, and then we can correct the arch form. So we can make it very fast. Okay. Yep. arranged all the 6 teeth now. They're positioned well, and we have also checked the arch form, whether it is confining to the sulcus and the shape of the arch, as well as the canine position. As we have marked there, the canine positions are reasonably good. Okay, so that gives us a good indication. Now, since a lot of this wax I did not remove, so I just redistributed it. So you can see the difference when I have redistributed it here, the wax, and here I removed part of this bunch of wax, and then I need to add a little wax there to get the shape done. Okay, so as we do the anteriors, remove all the wax from the palatal side, and then we can go on to arrange the mandibular anteriors. Now, once we have arranged the anteriors, the maxillary anteriors, then we need to put it back on the articulator, and we can raise the pin because the posterior part of the occlusal ribs can maintain the vertical at this point, and then we check how much is the overjet. All right, so generally it will be about 1 to 2 millimeters maximum. If it is more than that, then it is we consider it as class 2 situation or retrognathic mandible. Then before arranging the mandibular anteriors, we need to adjust the incisal guidance table, because at least arbitrarily we have to adjust so that later on we can check it in the patient for the overjet overbite and finalize it at the patient. Now, to start with, we are going to change the angulation here to 10 degrees. So generally it will be just loosen this lower one, loosen the lower screw, thumb screw, and this can be rotated. So there's 0, 10 and 20. So we are going to keep it to 10 degrees and then tighten it. It's difficult for you all to see, so trust me. The same way here to the lateral guidance also, we are going to keep it to about 5 degrees or maximum 10 degrees. We never have to later on, it also depends upon the condylar guidance. The incisal guidance will not be more than the condylar guidance. So generally we keep it to between 5 and 10 degrees of incisal guidance so that it will be useful for the arrangement of teeth. Okay, so I have adjusted here for 10 degrees of the anteroposterior and about 5 to 7 degrees here on both the lateral sides. Okay. Now we also have to keep the condylar guidance, say about 25 degrees, 20 to 25 degrees as an average, because we try to check it up, check the anterior teeth arrangement for a balance before actually put it in the patient. And we also have to adjust the lateral condylar guidance. So if we are keeping this about 25, then if we apply the formula h by 8 plus 12, it gives me around 15 degrees. So I have adjusted here to 15 degrees on both sides, and I have locked the centric locks. Okay. Yeah, as we start arranging the mandibular anteriors, again we have to have the midline marked and extend the midline to the mandibular occlusal rim. That is very important, so that it helps for us to arrange the teeth. Now, while we are arranging the mandibular anteriors, we can do it in 2 ways. We can either start from the central incisor and go ahead, or since we already have the maxillary canines in position, we can arrange the canine first and then come towards the central incisor. Once the canine is arranged in central incisor, and then we go to the lateral incisor. Okay. So now we are going to start with the canine first. So I'm marking here where the canine is going to come. The tip of the canine is here. So my mandibular canine should terminate, the distal proximal surface of the mandibular canine should terminate here. So the same way on this side, I'm going to mark there the tip of the mandibular maxillary canine. So the mandibular canine should terminate here. Okay. So now from here I can start doing the arrangement. Yeah. All right, you can see now I have arranged the canine. What I have done here is I have given a small overbite to the overlap. What I also did was a small trick. What I did is I have loosened it here. I moved to the canine position, and then I lock at this point. And then when I place the mandibular canine, it will not have any interference and the required amount of overlap can be achieved there. So you can see here we have got the amount of overbite that has been there, and the overjet also gets automatically adjusted. At the same time, since we have marked here where is the tip of the canine, so the distal proximal surface of the mandibular canine is coinciding with it. Okay. Okay, so here you can see now I have arranged the central incisor, mandibular central incisor. So what I did again here is, in order to get balance for the 10 degrees, what I have put the incisal guidance here, I bring it down, loosen it enough first, and check for the movement, the free movement on both sides. Okay. Then I'm moving it to the protrusive position and I lock it there and see that the teeth remain in contact. Okay. So we can see here the incisors are edge to edge when it is in protrusive, and when I unlock it, it comes back to the centric, and there we can see that there is the overjet and the overbite. Okay, so that is how we do it for the central incisor. Now we can go ahead and arrange the lateral incisor. If the lateral incisor, if the space is sufficient, we can directly arrange it, or if it is wider, probably we may need to grind it a little bit. Then we can take a choice either to grind both the central incisors or a little bit of canine to provide the space for the lateral incisor. Here I may need to grind a little bit of the canine, and then I can get enough space for the lateral incisor to arrange. So here, taking the guidance from the lateral, the central incisor and the canine, I have arranged the lateral incisor, and then I just check whether what we have achieved to establish the anterior guidance and the anterior balance. So when I try to move this into protrusive, I have nice contacts between the central incisors and the lateral incisor and the canine as well, and there is no rise in the pin. That is important. So when we are taking it to protrusive, there should be contacts here and the pin should be remaining in contact. So that means we have established the anterior guidance for the anterior teeth. Okay. So here again, I'm following the same pattern as I started with the canine. Then I've arranged the central incisor, and now I'm going to place the lateral incisor in that space, and then it just fits in there. Right, so just check for the plane, and then we can put it on the articulator and check for the protrusive. Okay, so just loosening both the sides, and then check for the protrusive. As we go back here. Okay, I think that's fair enough. There is no a small adjustment that was required. So I'm keeping in protrusive and trying to adjust these central and lateral incisors, so it will be having the incisor to incisor contact. Okay, that's good.